Yes, sir.
Yes, sir.
Okay, good.
Good evening, respected professor. My dear students, I welcome you all to our second session on the basic sciences in anesthesia. Today, professor will be discussing on the topics covering respiratory.
Hello.
Yes, sir.
Your voice is breaking. Konja ennanu pathriya?
Yes, sir.
Okay.
Is it okay, sir? No?
Now it is better.
Yes, sir. Thank you.
So let us not waste time. What is your feedback on the last class on cardiovascular system basic science? Supriya?
It was good, sir.
It was good. What about Sia? Sia is there?
Very systematic, sir. Lots of important things.
Okay. So the
Yes, sir.
same way, instead of studying anatomy separately and then physiology, biochemistry, as we all know that we start our medical curriculum with the basics. First year we study anatomy and physiology, biochemistry. Then we go on to study the pathology, pharmacology. Then come to the clinical side to medicine, OG and surgery. Okay. So the same way, we'll have to have a comprehensive idea about all the systems, starting with the basics of anatomy, physiology, biochemistry, and go to the pharmacology, as well as pathology, and then go to the clinical systems of the various systems. And for the DNB students, my idea is to incorporate some of the ASCII-like questions also, so that these ASCII questions are asked from either basic sciences, pharmacology, or the clinical scenario. So I thought of incorporating everything into the class so that we will have an overall idea about how to manage these questions when they are asked in either in the theory or in the practical exam. So I'll share my slides with you. Is it visible?
Yes, sir.
Yes, sir.
Okay. So I'll make it full screen. So the this is the pattern or the overall important topics or the subdivisions of the topics that will be dealt with today. And these are the 4 common anatomy questions that are asked in the theory again and again. One is about the lateral wall of the nose, which also is the beginning or the starting point of respiratory system. Then the air flows through the nostrils and the mouth to the larynx, and after entering the larynx, it goes through the tracheobronchial tree, and the main muscle of respiration is diaphragm. So diaphragm is the main muscle to cause the inspiration by its contraction. And all of you know that expiration is a passive process. So just the recoil or the relaxation of the muscle results in the contraction and reduction in the space of the thorax, and lungs are squeezed. And so expiration is more of a passive process, whereas inspiration is an active process requiring the contraction of the diaphragm. And in the physiology, the main things are the control of respiration. This will be the main basic physiology, which all of you would have read in the physiology training time. And then the purpose of the respiratory function is for taking the oxygen into the body and eliminating the carbon dioxide. So we'll have to learn about the oxygen, how it is taken in, what is the cascade or how the pressures gradually decrease, and how the flux happens and the transport. And similarly, how carbon dioxide is eliminated after it is produced by our metabolic activity. And some few gray areas normally causing a little bit of confusion among the students is the compliance, resistance, elastance, and all those terminologies which we will see. And as an anesthesiologist, we have to know have a very clear concept about dead space and the shunt. These two things are to be learned very well, and how the alveolar ventilation happens, and some of the non-respiratory functions of the lung. Lung not only serves the function of oxygenation and elimination of carbon dioxide, but in addition to that, it has got some non-respiratory functions. And we'll have to also learn about the positive end expiratory pressure, which is usually employed as a means of improving the oxygenation and alveolar ventilation by exerting a pressure at the end of expiration to improve oxygenation, which is incorporated in most of the ventilators. And this hypoxic pulmonary vasoconstrictor reflex, HPVV, is another important adaptation or a protective phenomena which happens to prevent the so-called stunting or venous admixture. So these are all the important subheadings of physiology we will be dealing with. And we have very limited medications used in the respiratory system, and those will be the bronchodilators and mucolytics, which are mainly used. So pharmacology wise, we have very limited things. So again, like last class, it will be an interactive session. So I don't want it to be didactic, myself talking all the time. So if this question is asked, like describe the anatomy of lateral wall of the nose, can any one of you say what are all the things that you will write in the answer paper? How to answer this question, lateral wall anatomy? Is it made up of bones or cartilages? Does it have what is the blood supply? What is the nerve supply? See, anatomy questions are only like that, you know, you have to describe the structures. So how many turbinates or cartilaginous bones are there? The lateral
Lateral
wall.
wall will be cartilaginous with 3 turbinates, so superior, middle, and inferior turbinates. Sound paper.
Very good. So is it a straight wall-like structure, or is it a curved, rolled up structure? The turbinates.
Hold up, sir.
Rolled up. They are not straight like your septum in the middle of the nose. Okay, so they are all curved or coiled structures, and there is a recess between the turbinates. Okay, so what is the name for that recess? Concha. Okay, so this is the picture that you have to remember. So you have a superior turbinate, middle turbinate, and inferior turbinate, which is also called concha because it looks like a shell. When it is rolled out, it looks like a seashell which you see in the seashore. Okay, so it is rolled up like that, and you have the meatus, the openings of some of the important sinuses which are adjacent to that. So the entire lateral wall is a part of the skull. Okay, it is not a part of the mandible or anything. It is part of the maxillary part of the side of the skull. And so the this is the picture to have an idea. Then it is made up of 3 nasal turbinates, inferior, middle, and superior. These big positions are that, and there are ostia or openings which are there inside the between these turbinates, and the opening of nasolacrimal duct, which is the duct opening from the eye, that is also there in the lateral wall only. And see, these are all the openings that you will see. You have the ethmoidal sinus opening, you have the frontal sinus opening, you have the maxillary sinus opening. Okay, so all the sinuses, which are nothing but, what is the sinus in this? How do you define the sinus? It is the air-filled space inside the bone. Okay, why there is air and the sign? What is the purpose of these sinuses? You would have been taught in your anatomy classes. What is the purpose of all these sinuses? Is it to produce sinusitis? Or is there a normal function for the sinus? Instead of being filled with marrow, if the bone is filled with air, will the weight increase or decrease?
Decrease, sir.
Decrease.
So if a cavity is filled with air, will it have some resonating quality? Like
Yes, sir.
when you
Yes,
blow
sir.
into a hollow organ, you'll have some resonation, isn't it? So
Yes,
it
sir.
helps. All the sinuses are there. One, to reduce the weight of the bone. Second is to improve the quality of your speech or phonation. Okay, so the voice resonates through these air-filled spaces, and it gives your uh, tone, or your voice is made more clear by the sinuses. But if they get infected, that gives you a lot of problem. You develop sinusitis, more secretions come, and then it fills, you get pain. And if these ostia are not opened all the time, whatever minimal secretion happens, they have to drain through that. And when they are blocked, you get a severe infection there, and you require a surgery called, what surgery is done to open up the ostia and drain the collection inside the sinuses, especially the
Pest.
maxillary? Pest surgery, functional endoscopic sinus surgery.
Yes, sir.
Okay, so it produces restore the function of the sinuses. That is why it is called functional endoscopic sinus surgery. Okay. Now, what are the bones and cartilages of the lateral wall of the nose? We saw that these three most important bony structures, turbinates, are there, but which bones form these turbinates? You have several bones in the skull and face. So you can remember that you can name anything and you'll be all right. Okay. So if you see this is the these are the bones: nasal bone, maxilla, lacrimal bone, ethmoid bone, inferior nasal concha, perpendicular plate of palatine, medial pterygoid. So there are 7 bones which form the which give the framework for the lateral wall of the nose. And the cartilages are lateral nasal cartilages and the alar cartilages of the nose also forms it. So the ala is this portion of the nostril, the curved portion on the outside towards the lateral angle of the mouth is the alar portion. So that cartilage also gives rise to the framework. So there are 7 bones: nasal bone, maxilla, lacrimal, etc., and cartilages are there. So the second answer you have to be right in the question if it is asked is which bones and cartilages constitute the lateral wall of the nose. Then what are the functions of the nose? Now that the function you can write as the last part of the answer if it is an anatomy question, but I am just including it in here to know what is the function before we proceed further about the blood supply, nerve supply, and its importance. What are the functions of the nose?
For breathing,
Breathing, yeah. So when we breathe through the nose, what happens to the air that we breathe in?
it gets humidified.
Humidified.
It is humidified. Before that, does the air contains a lot of pollutants or dust particles? Is our air very pure?
No, sir, it contains particles.
So what happens to those particles? What is the function? What is the important function of the nose in filtering that air, isn't it? So it filters heat and exchange, humidification, filtration of all the dust and other particles, and it causes some amount of resistance because it's a narrow passage. Anything which is narrow, it takes a bit of effort to pass through that. Any flow of gases will take a little bit more effort. So it causes resistance, and it can also produce some fluids, and it has got hairs which are called vibrissae. So larger particles are all caught in that vibrissae, and they form a coating with the nasal fluid and encrust them and retain them without going into the lower respiratory tract. And there is a nasal neurovascular reflex. Suddenly you can sneeze, you can get a bradycardia unexpectedly if somebody tickles or stimulates the nose. And it also gives voice modification, especially if a patient has a cleft lip and cleft palate as a congenital deformity. You have to do the nose correction and palate correction to them with a proper voice. Otherwise, they will have what is called the nasal twang. So the nose is also important for voice modification. And another important function is the smell. So olfaction is a very important function, and this only gives you to distinguish between a good smell and a bad smell, and protect yourself from exposing yourself to anything noxious. Okay. The next is the blood supply. What is the blood supply to the lateral wall of the nose? These are all the arteries which are supplying that. We have seen the major constituents, the three turbinates. Then we have seen the bones and cartilages which constitute or form the lateral wall. Then we have to say about the blood supply. Is it having a rich vascularity or a poor vascularity? The nose.
Rich
Rich
vascular.
vascularity. What is the purpose of that rich vascularity? You said the function. That is why I included the function. Humidification and heating up. For that you require the blood supply. Okay. So if you see, you have the anterior and posterior ethmoidal arteries. They are branches of which artery?
Internal carotid arteries.
Directly from internal carotid?
Ophthalmic branch.
Ophthalmic branch. Very good. Ophthalmic branch of internal carotid. And this sphenopalatine and greater palatine?
From external carotid arteries.
They are from external carotid. So they are all high pressure artery branches. Okay. And you have the superior labial artery, which is a branch of
Septal branch of facial artery.
facial artery. Okay. Septal branch is a branch of superior labial artery, but superior labial artery comes from facial artery. So the anterior and posterior ethmoidal arteries are branch of ophthalmic artery, which is a branch of internal carotid. Okay. Then you have sphenopalatine, greater palatine arteries, which are branches of maxillary artery, which is a branch of external carotid. And you have the superior labial and lateral nasal branches of facial artery. So all these things are the blood supply. And this area, which is called the Little's area, what is the importance of that? It is also called Kieselbach's area, where branches of greater palatine and anterior ethmoidal arteries and superior labial arteries, they all form a plexus. So what is the importance of this area?
Epistaxis.
Epistaxis, very good. Whenever patient gets epistaxis, bleeding usually occurs from this area. Okay, so your aim must be to apply pressure over this area to stop the bleeding. So you must pack the nose in such a way that you apply some good pressure over this Little's area or the Kieselbach's area if supposing a patient lands up with severe epistaxis as an emergency. Okay, that is the applied anatomy of this particular arterial blood supply. What about the venous drainage? Where do the veins drain and what is its clinical importance?
Facial vein and pharyngeal plexus vein.
Facial pterygopalatine. Usually, it goes into the veins drain into facial vein, pterygoid venous plexus, pharyngeal venous plexus. Okay, these are the three major sources of blood venous drainage. And what about the nerve supply, which is very, very important for all of us as anesthesiologists? Whenever you do want to do any nasoendoscopy, fiber optic intubation, or awake blind nasal intubation, this question will be repeatedly asked in the examination. So which are all the nerves you have to block if you want to do any instrumentation in the nose?
Anterior and posterior ethmoid nerves.
Ethmoidal. So this picture will tell you all about that. Olfactory is mainly for the smell. That is also part of the nerve supply. And you have the anterior ethmoidal nerve, you have the anterior superior alveolar nerve, you have the nasal branches of greater palatine nerve, and this sphenopalatine nerve. So anterior part is supplied by the anterior ethmoidal nerve, which is a branch of nasociliary nerve. And the inferior part is supplied by anterior superior alveolar nerve, which is a branch of infraorbital nerve. And posterior superior part is supplied by the superior lateral nasal nerve, which is a branch of pterygopalatine ganglion. And posterior inferior part is supplied by nasal branches of greater palatine nerve, which is again a branch of pterygopalatine ganglion. So for the sake of nerve supply, you have to divide the whole nose into anterior superior part, anterior inferior part, posterior superior and posterior inferior. Both the posterior and superior and inferior parts are supplied by branches of pterygopalatine, whereas the anterior parts is mainly by infraorbital and nasociliary. So even if you don't remember the branches like anterior ethmoidal or anterior superior alveolar, even if you say in the exam nasociliary, infraorbital and branches from pterygopalatine, these three nerves, if you remember, that's good enough. So you can say that these are the nerves which are supplying, and that these are the ones required to block. And olfactory is mainly for the smell. Now, why nose receives such a rich blood supply? Already we have seen the answer for that. It is for the effectively change the humidity and temperature of the inspired air. So the nose receives blood supply from both high pressure vessels like internal and external carotid arteries branches. What is the importance of venous drainage of the nose and its clinical implication? This is the question that I told you that we have to, why we have to know that it is drained by facial, pterygopalatine and pharyngeal plexus. What is the importance? Is there any
Prof,
other
plexus
connection
can be a
more than
source.
this to the venous drainage of the nose?
Spread of infection through the sinuses into the brain.
Excellent, fantastic. So the veins now tend to follow the arteries. They drain into pterygoid plexus, facial and cavernous sinus also. This is a very, very important communication where the facial veins and other things drain. So few nasal veins join the sagittal sinuses also. So this represents a potential pathway for infection which can spread from the nose to the cranial cavity. So this is a very important applied anatomy we have to know. So this is called the danger triangle of the face. So if any infection occurring in this area, so anybody getting a boil or any pimple in this area, you should not neglect. If it is not attended properly, and if the patient has reduced immunocompromised, if the patient is an immunocompromised patient, they can develop a infection in the cavernous sinus or in the sagittal sinus and go in for thrombosis of those veins. So this is one of the important applied anatomy. And as we saw earlier, whenever we have a bleeding, we have to pack this area. And this little area is common site of bleeding for epistaxis. Now, what are the causes of nasal airway obstruction? Is it because of the bones, cartilages, or mucosa or septum? Which causes nasal obstruction? Because many a times when you want to do a nasotracheal intubation, first step you have to assess the patency of the nostril through which you are going to introduce the nasotracheal tube. So right or left nostril, you should assess the patency and size so that you don't traumatize by putting a larger tube into a narrow space. So what are the causes of nasal obstruction?
Deviated
Commonly
nasal
when you have a
septum,
cold,
Deviated.
you get a nasal obstruction, isn't it?
sinonasal polyps.
Polyps can happen. So nasal airways are formed and supported by bones of the skull, and they don't need any internal artificial support. But it becomes easily obstructed by congestion and edema of the mucosa. This is the commonest reason. All of us would have experienced. Whenever you get a cold, you find it difficult to breathe through your nostril. You sit up in the night. I have suffered as a final year student. I used to keep awake all through the night, and in those days we used to get only ephedrine nasal drops prepared by the hospital where I studied. And that 5% ephedrine will be given, and I used to apply it every half an hour and struggle a lot. And then when I went to the ENT surgeon, they said I have a deviated nasal septum, and I was scared to get operated. Luckily, something happened, and I got over that. And in children, the adenoid lymphatic tissue can cause chronic obstruction. Okay, so this is the applied anatomy. And in a pediatric patient, when the patient comes crying to the OT because of separation from the mother or the parent, then it will have a congested blocked nose. And when it is crying, this will not be very obvious. But once you induce anesthesia, then you may have a severe obstruction because pediatric patients are obligate nasal breathers. They don't know how to breathe with the open mouth. So once the nose gets choked or clogged, they will be struggling to breathe. So whenever you get or take a baby inside the OT crying very vehemently in the pre-anesthetic room, always keep an oropharyngeal airway ready so that once you induce the child and patient loses consciousness, there will be total obstruction of the nasal passage. So unless you put in a oropharyngeal airway, you will not be able to ventilate the child. And this oropharyngeal airway should be smaller than the regular size. And because if you put it a correct size oropharyngeal airway, that may produce a gag reflex and that may induce a laryngospasm, especially when the child is lightly anesthetized. So always use one size smaller just to separate the lips so that oxygen can be pushed into the oral cavity. And elderly patients with no teeth, they're similar situation. Usually we do the chin lift and jaw thrust for opening the airway. But if the patient is totally edentless, doesn't have a teeth on the upper and lower jaw, then the mouth will collapse like this. And when you do the chin lift, it will completely occlude not only the nasal passage but the oropharyngeal cavity also. So here also, either you ask the patient, whenever I get a patient with complete dentures to both the upper and lower jaw, I always ask them to wear it and come to the OT so that you will have a proper fitting of the mask as well as this problem will not happen. So always remember that point that full dentures cannot be aspirated. So even if it gets dislodged, it will be lying only in the oral cavity. So there is no risk of any foreign body aspiration. So please remember, patients with full dentures, removable dentures to both upper and lower limb, lower jaw, ask them to wear the dentures and come to the OT. And after induction, if you want, you can remove that after you intubate the patient. Now, how to prepare the nose by topical anesthesia and medication for any instrumentation. So what are the techniques of anesthetizing the nose?
Nasal,
this is another question. Huh?
Basal constrictor with like oxymetazoline, xylometazoline, nasal drops.
Very good. That is not anesthetizing. That is to reduce the congestion. But that is the first step, right? What you are saying is right. We must reduce the vascularity and the congestion of the mucosa so that the passage will expand. Right? Very good. Then application of local anesthetic. What percentage local anesthetic commonly we use? What percentage?
4%.
4% lignocaine. Very good. Excellent. So why we require a larger percentage compared to your blocks, like when you give a plexus block or a neural block, you are using only 1% or 2% lignocaine or 0.5% bupivacaine. But when you want to do a surface application, like installation into the nasal cavity, why you require 4%? Okay, think over it and tell me. I will otherwise I will tell the answer at the end of the class. So insertion of nasal airway, esotracheal tube or fibroscope. Use a topical first vasoconstrictor in order to open the upper airway and prevent mucosal damage. Okay, this is not going to anesthetize. This is only to shrink the mucosa. This is the first step, and it is going to take time. When you apply Otrivin or Nesivion nasal drops, it is not going to immediately shrink the thing. So it has to be applied several minutes before, applied sufficiently early. Okay, so vasoconstrictor like Otrivin, whatever you use, you should apply it at least 15 to 20 minutes or half an hour before you bring the patient to OT, number one. Then 4% lidocaine is suitable topical anesthetic for nose, pharynx and larynx. And you can use that, the technique of spraying that is drip the local anesthetic directly with a 2 ml syringe or just put it through a fine needle attached to that. But what is the modern method of utilizing, anesthetizing the mucosa in a uniform way? this dripping or squeezing with the 2 ml syringe, it may not uniformly spread in all the areas. So which is the best method to give a uniform coating of the local anesthetic?
We can soak gauzes or peg legs and keep it in the nasal mucosa.
That is going to take a little time, like what the ENT surgeons
Nebulized
do.
like lignocaine, sir?
Nebulized or atomized. Okay, atomizing using oxygen flow can be used to spread have a uniform and even spread of the local anesthetic. Okay, and what are the indications and contraindications for nasal airway devices? When should you, especially in trauma, when you have a trauma head injury patient, which patient should not have any nasal instrumentation done?
Base of skull fracture.
Base of skull fracture, fantastic. That is the most dangerous thing. Patient semi-conscious also, you should, indications is when the patient is semi-conscious, they tolerate nasal airway better than oropharyngeal airway. Okay, so that is the indication. And do not use the nasopharyngeal airway in base of skull fracture because that can enter the cranial cavity directly because of the fracture in the ethmoid bone. When you try to introduce that, it may go and injure the brain by entering the cranial cavity. So any base of skull fracture, you should never use any nasopharyngeal airway. When is the nasotracheal intubation needed? How much more length is needed of the endotracheal tube? What are the indications for nasotracheal intubation? All of you would have seen many cases being operated with a nasal intubation.
In case of
Commonly-
difficult airway, OFMS surgery, awake
Adeno-
fibrotic.
Adenotonsillectomy.
Adenotonsillectomy, very
Tonsillectomy.
common thing. ENT surgeons,
Adenotonsillectomy.
unless they want to do an adenoidectomy also, they may request nasal intubation if it is going to be a pure tonsillectomy alone. And any oral surgery,
Oral cavity surgeries.
like any partial glossectomy or
buccal
mandibulectomy, in all those cases, we have to do a nasotracheal intubation. And how much more length to be introduced into the trachea compared to oral cavity? Oral intubation is to be 2 to 3 centimeters more. Okay, so the use of nasal tube follows free surgical access to both and helpful in dental, maxillofacial, plastic, and ENT cases. These are all the surgeries where they may request you for a nasal intubation. And it is usually you have to introduce the tube 2 to 3 centimeters. For example, for oral intubation at the incisor level, for an adult patient, it will be usually about 19 to 22 centimeters, depending upon the length of the neck. But in nasal intubation, it has to be 24 to 26 centimeters. So 2 to 3 centimeters longer than the oral route. And blind nasal intubation can be a valuable rescue technique in case of unexpected difficult laryngoscopy also. So what preparations are needed for nasal intubation under direct vision? Direct vision means you are going to put in a laryngoscope, McGill's laryngoscope, McIntosh laryngoscope, and visualize and then do it. So what will a conscious patient tolerate this?
Lubricate the nose and tube.
So you have to first properly anesthetize the nose and oral cavity. Then you have to always well lubricate the tube, soften the tube by immersion in warm water for a few minutes. Then bend the tube to insert the bevel into the connector and leave it for a few minutes to reduce the McGill's angle. Okay? So this is what you have to do. So insert the bevel into the adapter and leave it like that so that this angle becomes more acute. What is the normal McGill's angle of a oral tube? When the tube is not bent like this and now you have a normal tube, what is the angle produced by that McGill's? That's called the McGill's arc or the McGill's curve. Okay, let's also keep your answers searching. I will tell you then. So although some resistance is common, never use excessive force. Okay. If you are unable to advance the tube through the nostril that you have selected, Don't push it through that. Try the opposite one. Check your angle of insertion, whether it is parallel to the floor of the nose. Try gentle rotation of the tube. These are all the techniques of intubation to see the tube when you want to do a nasal intubation. Or try inserting it through the other nostril. So lubrication, warming the plastic tube so that it becomes little softer, and then increasing the curvature by bending the tube, and then selecting the patent nostril, and then inserting the tube gently without force. And if you are not successful, change to the opposite nostril and never use force to cause any bleeding. Okay, these are all the few practical points you have to keep in mind. And otherwise, you go for a smaller size tube also. If you have selected 7 and it is not going, don't keep on repeatedly trying with that. Go for a 6.5 cup tube so that if you inflate the cup, it will not cause any further problem. Now, what is the current technique of local anesthesia for fiber optic nasal intubation?
Spray as you go, sir.
Spray go technique. Spray as you go is the current way, so that you don't have to wait for a long time spraying or using a nebulizer or atomizer. So you can just split the local anesthetic and then start inserting, and through the working channel you can keep on injecting the local anesthetic under vision and wait for a few seconds for the effect to come on. How fast the local anesthetic will act once it is instilled on the mucosa? How much
Minimum
time
of
will it take?
20 minutes, sir.
20 minutes. Have you all seen a blotting paper? And the common practice was to use pens filled with ink from the ink pot. In those days, they used to have a paper called blotting paper, because the excess ink that is spilling on the paper will be immediately removed by using the blotting paper, like just mopping it on the lines that you have written. So the speed with which the anesthetic action comes on mucous membrane is compared to that. So it acts as fast as a blotting paper absorbing ink. So that much within seconds it will act. Tomorrow when you go to theater, take a small drop of 2% lignocaine and put it on the inner side of your lip and see how fast it acts. You will be surprised. Within no time your lip will become numb. Okay. So how to confirm the correct placement of ET tube by fiber optic scope?
So we check for the positioning above the carina.
No, once you have entered the trachea and you have placed the tube, how do you know that you have entered only the trachea, and where should you stop pushing the tube?
Until the carina.
You
In the
must
carina,
really
sir.
visualize the carina. The two major bronchi indicate the correct tube position. So it will be looked like. This is the carina. This is the opening of right main bronchus. This is the left main bronchus. So whenever you try a nasotracheal or a orotracheal intubation and with a fiber optic scope, you should not advance the tube further once you see this picture. Okay, so once you visualize the carina, you must stop. What are the advantages and disadvantages of giving oxygen through the nasal route? Nasal oxygen therapy. This is another clinical application of the nose.
Apneic oxygenation will increase the safe apnea time.
Okay, that is the technique I'm asking. Advantages that it does, whether you give by nasal prongs or your Hudson's mask or your venti mask or your high flow nasal oxygen cannula, whatever device you use and give oxygen, what are the advantages and disadvantages? That is the question which is also asked in the OSCE. They may give you an oxygen delivery device and ask you what are the, for example, if you have the binasal prongs, what are the advantages you will say?
Easy for the patient to.
Patient will be very comfortable. Nothing will be pressing on the nose and part of the face. So it is very easy for the patient. It's comfortable. Can he drink and eat with that nasal prong?
Patient can eat.
Yes, sir. You can
He can take fluids. He can eat whatever he wants. Can he phonate?
Yes,
sir.
sir.
Yes, sir.
He can talk. All these things are advantages. But what is the disadvantage of this nasal prongs that you are going to use?
Drying of the
Drying
nasal
of
mucosa
Unless it is
and
humidified, may cause
limited flow.
dryness, but your normal mucosa will help in that. Okay, so prolonged dry gas supply will cause a dryness of the mucosa. So nasal oxygen allows patients to eat, talk, and cough normally. And if prongs are used, it can do the job of humidification without separate need for a humidifier. And high flow gases increase the FiO2, but that they can cause dryness of mucosa. And what surgeries are performed on the nose or through the nose, and how anesthesia administered for them? Mostly cosmetic. Have you ever seen cosmetic surgeries being done on the nose? What are they called?
Rhinoplasty.
Septoplasty and rhinoplasty. Very good. So rhinoplasty, making the especially people in the film world. Sri Devi got her claim in the movie after she underwent a rhinoplasty with the surgeon with whom I was working. Okay. After that, so every other lady artist wanted to have a rhinoplasty done to achieve the fame and money. So tip plasty, septal plasty, so open or closed rhinoplasty can be done under local anesthesia or topical infiltration or GA. And the knowledge of sensory innervation will help to provide good analgesia for the surgery. Okay? And the next question you will be seeing is, what is the external nostril supply? Internal nostril supply we saw in the previous slide. You will have to know the nerve supply for the outside of the nose also. And whenever you do any nasal surgery, you will have to have a proper throat pack so that the blood that is oozing out going into the pharynx will be absorbed by this throat pack, and you can prevent aspiration into the lungs. And one neurosurgery procedure which we do through the nose is transsphenoidal pituitary excision, adenoma excision through the sphenoid by inserting the video camera and the it is an endoscopic surgery, so that is done through the sphenoidal thing, where you do an oral intubation with a cuff tube, especially ray tube or a flexometallic, and you have to place a throat pack for that. And the fist and septoplasty, which all of you would have been familiar, that is also done through the nose, and for that also we do only a oral intubation, throat pack, and surgeon may request for hypotensive anesthesia. So either you put vasoconstrictor like phenylephrine or adrenaline soaked gases to reduce the bleeding from the mucous membrane, or some prolonged cases surgeon may request for hypotensive anesthesia also. So these are all some of the practical points which you have to know about nose surgery. And what is shown here?
Turbinates.
Turbinates are seen. Can you name all these 1, 2, 3, 4, 5, 6 that are shown here? What is 1?
Inferior turbinate.
Inferior turbinate. Very good. 2. The gap between the septum and this thing. 3 is the middle turbinate. Okay. Usually you see only these two turbinates. Middle and the inferior will be, superior will be very small. You cannot see that usually. Okay. So the structures seen through anterior rhinoscopy. So this picture shows the structures that are seen through the anterior rhinoscopy, and these are all the structures. One is the inferior nasal meatus, second is the common nasal meatus, 3 is the middle nasal meatus, and 4 is the nasal septum, and 5 is the middle turbinate, and 6 is the inferior turbinate. So this is actually the turbinate, which is the arrow is pointing on the turbinate itself. These are all the recess or the gap between the turbinates. And what is anterior rhinoscopy and what instrument is used to do that? All of you had passed ENT as a separate paper, isn't it, during UG days? So which instrument do the surgeons use to visualize the anterior part of the nose? Nasal? Speculum. Have you not seen this being used by ENT surgeons when you are posted in the ENT department for your training as UG? This is a very commonly used speculum to inspect these structures. Okay, so nasal is. But when you want to see the posterior part of the nose, which is called posterior rhinoscopy, which instrument is used? Can you see anything posterior by using this speculum alone?
No, sir.
Yeah. So which instrument you have to use? You have to use the nasal cavity through the pharynx. It's inserted by inserting a mirror. So this is the mirror that they will be using. Ask the patient to open the mouth and insert the mirror under the uvula to see what is being there in the posterior part of the nose. So this is called the posterior rhinoscopic mirror. Okay. And next practical application is what is a nerve supply of external aspect of the nose. What are all the nerves which are supplying the skin over the nose or the root of the nose and the ala and all these areas?
Branches of trigeminal nerve, sir.
Branches of trigeminal. That's a very vague answer. Must be more
Maxillary.
specific. Huh?
Maxillary branch of trigeminal nerve.
Maxillary. Yeah.
Ophthalmic
This
branch.
picture. So you have 4 nerves. Supratrochlear nerve, which is going to the root here, infratrochlear nerve. Then you have external branch of anterior ethmoidal nerve, and there are branches coming from infraorbital nerve. Okay. So if you want to do a rhinoplasty under local infiltration, these are all the areas you have to infiltrate. You have to infiltrate at the supratrochlear notch will be there. So you have to give 2 ml to block the supratrochlear nerve. Just immediately 1 centimeter below at the root of the nose, you can block the infratrochlear nerve. Then at the middle of the nose on the lateral aspect, you can block the external branch of anterior ethmoidal. And below the corneal, below at the lower border of the orbit, almost at the midpoint, below a imaginary line drawn from the middle of the pupil, you will get the infraorbital nerve coming out of the infraorbital foramen. So if you block all these 4 nerves, you will have excellent analgesia of the skin. And then you can block all the 3 nerves which we saw there on the branches of ethmoidal nerve, the branches of pterygopalatine and the maxillary nasolabial for internal anesthesia by packing. So what are all the methods that are going to be done? We can see this. What is being done here? This is a nebulizer being inserted and the cavity is being anesthetized using a nebulizer with 4% xylocaine 5 cc and compressed air or nasal oxygen cannula. You can use that for atomizing or nebulizing and anesthetizing the mucous membrane. So this question, Moffat's solution and its use. This is a very common question that can be asked if you get a nasal case in the practical exam, or sometimes this is also asked as a part of the OSCE questions. Have you heard of this name, Moffat's solution? Yes or no? Okay.
No,
So it
sir.
is a mixture of 2 ml of 10% cocaine. It was the oldest local anesthetic. With 1 ml of 1 in 10,000, that is 1 ampule of adrenaline, and 2 ml of soda bicarb. So totally 2 plus 1 plus 2, 5 ml, diluted with 5 ml of normal saline. This combination or this mixture of local anesthetic and adrenaline with the bicarb and diluted with normal saline, this combination was used by one Dr. Moffat, who was a major in the British Army. And he was an ENT surgeon, so he used it for all the surgeries on the nose, like rhinoplasty and septalplasty and all those things. And now it is obsolete because the concentration of adrenaline he is using is very, very high. Now we are using very, very diluted adrenaline. But during his time, and cocaine also, unlike other local anesthetic, what is the difference between the action of cocaine and other local anesthetic on the vasculature?
Vasoconstrictor.
Vasoconstrictor. So cocaine by itself will cause vasoconstriction. On top of that, you used to use so much of adrenaline. So you will have an absolutely bloodless feel. So that is the reason why he used it, and that is called Muppet solution. It is no longer used except for torturing the patient and students in the examination. Okay. So, but you have to learn this. And what is this picture showing?
Nasal packing.
Nasal packing, sir.
Nasal packing with the, this is,
Gauze.
I'm
Ethylene
showing all-
soap.
it is a gauze, roller gauze. Okay, so it's a roller gauze soaked in 4% lignocaine, which is the method of packing it. You have to pack it in between the terminates, okay, like this. In serial, you can just, it is not like stuffing a pillow into the pillowcase. You have to do it in a methodical way, in this fashion. Then you will have complete anesthesia by the absorption of local anesthetic from the gauze piece onto the mucous membrane. So if you don't pack it in this way, just push it with a gauze piece in any fashion that you like, you will have only partial anesthesia in some areas may not be anesthetized at all. So for a proper, this is a technique of packing the nasal cavity with LA soaked roller gauze. What is the instrument that is being used? You can see there is a curve in the instrument, and what is the reason for that? That is the meaning of this part of the question. What is the instrument used and why that instrument is used? All of you would have seen ENT surgeons using this in your ENT posting days. So this is called the bayonet forceps. Okay. Bayonet means it's a gun. It's a long gun which the army people use. Okay. So there is an angulation. You can see it is not a straight forceps. There is a bend here. This angulation helps you to see the tip of the forceps. Okay. So that you know where exactly you are placing the gauze pieces. If it is a straight, your fingers will be occluding your view. So that is the reason why that is why your Begel's forceps also has a similar curvature. The examiners may ask you what is the curvature, why that curvature is there. It gives you a clear view of the tip. And which surgeries are done by this? Usually septoplasty and rhinoplasty. Okay. Now, what is this which you are commonly using it or must be aware of?
Nasal decongestants.
Nasal decongestant. Oxy, what the pharmacological name is? Otrivin is the commercial name, brand name.
Oxymetazoline.
Oxymetazoline. Okay. What is the mode of action? How does it cause nasal decongestion?
Vasoconstriction of the nasal mucosa.
Direct vasoconstriction. Very good. So the drug is used to shrink the blood vessels of nasal mucosa and help during nasal intubation by enlarging the passage, and they acts by direct vasoconstrictor effect. Okay, so these are all the applied sciences. So we have completed the anatomy of nasal lateral wall of the nose and its implications for anesthesia. Now we are descending down from the nasal cavity to the larynx. Now describe the anatomy of the larynx. This is the oft-repeated question in the theory paper. You will have to learn how to draw the pictures of the larynx. Again, like your nasal cavity, it has the cartilages, it has got muscles, it has got ligaments, it has a blood supply, it has a nerve supply. So you have to divide the answer into these headings. So what are the cartilages forming the larynx? Framework of larynx.
Three paired and
Three unpaired.
Very good. Paired and unpaired cartilages. So it is a segment of respiratory tract located in the anterior aspect of the nerve. What is the length of that? It is about 4 to 5 centimeters length and width, slightly shorter in the anterior posterior diameter. And it is, what is the location? It is at the C4 to C7 cervical vertebra. So this is the anatomical question commonly asked in the exam also. And what is the difference in a pediatric patient compared to adult? This is what values I am saying is for adult patient. In what way the pediatric larynx differs from the adult? That is a common question whenever you get a pediatric case.
It's bit anterior and higher.
Higher, C3.
Yes.
Okay. So instead of C4 to C7, it may be C3 to C5. Okay, has highly higher placed larynx, and the superior most part of the larynx is called the epiglottis, which is attached to the hyoid bone connected to the inferior part of the larynx, and inferior aspect of the larynx connects the superior region of the trachea. So it is the starting point of the trachea, which is placed above the trachea. And the skeleton is 3 unpaired cartilages. The 3 unpaired cartilages are thyroid, cricoid, and epiglottis. Hyoid is not a part of larynx, so please don't make that mistake. Even though hyoid is very visible and very palpable in the anterior aspect, hyoid does not belong to the framework of larynx. And 3 paired cartilages are arytenoid, corniculate, and cuneiform. They are all 2 in number. So this picture will tell you to learn to draw this picture of thyroid, cricoid, and epiglottis. These are the 3 unpaired or single number cartilages. Epiglottis is there, thyroid is there, cricoid is there. And the arytenoid, corniculate, and cuneiform are not normally visible unless you do a laryngoscopy and have a direct vision. Even epiglottis also will be seen only by vision inside the oral cavity. But thyroid and cricoid are the 2 unpaired cartilages which are palpable and visible outside. All the others are all inside, seen only when you do a direct vision. What is the histology of laryngeal cartilages? What is the difference? Are they different from the other cartilages? You have cartilage in the rib, you have cartilage in the bones of the limbs also before they become
Hyaline
ossified.
cartilage.
There are hyaline cartilage and elastic cartilages. Okay, so these 2 are distributed. Hyaline cartilages are present in thyroid, cricoid, and base of arytenoids, because these hyaline cartilages will become ossified after 25 years of age. Okay, whereas the epiglottis, corniculate, cuneiform, they are all elastic and they do not become calcified or ossified. Okay, so they will remain elastic all through your life. So that is the importance of the histology. What is the meaning of thyroid? What does that word thyroid mean? What is the angle formed by the 2 laminae of the thyroid cartilage?
Thyroid means leaf-like structures.
Means shield. Okay, thyroid means shield-like. It is like the shield that the Roman soldiers used to hold in their hand when they go for fighting. So it shields the entire respiratory passages. So that is the reason why the appearance, we called it a thyroid. It has 2 laminae and the angle formed is 90 degrees. That is a very acute angle, or the right angle rather. So that gives the Adam's apple appearance in male. Whereas in female, it is a broader obtuse angle, which is 120 degrees, and that is the reason why it is not very prominent in female. What is the structural peculiarity of the cricoid cartilage? This is the peculiarity of thyroid cartilage. Does cricoid have got any peculiarity?
It has got
What
a
is the meaning
complete
of-
ring.
It has a signet ring appearance. Okay, it has got what is called the signet ring appearance. It has a small anterior arch and a large posterior laminae. Okay, it's a signet ring shape. There's a small anterior arch which is about 2 to 3 millimeter. It has a posterior laminae which is about 5 to 7 millimeter. And you can see this is the anterior aspect. This is the posterior aspect. Why posterior is broader and anterior is smaller? Again, another food for thought. Think over it. Let us somebody keep noting all these questions so that we can answer it at the end. Okay, what are the parts of the arytenoid cartilage? Arytenoid is an important cartilage for many functions of the larynx, and if it gets injured or damaged, that will cause a lot of problem. Okay, so you must learn something about this arytenoid cartilage. Any idea? What shape is that arytenoid cartilage? It has more or less like a pyramid shape. Okay, you can see this is the arytenoid cartilage. It has got an apical process, and it has a vocal process and the muscular process. So almost a slightly broadened base triangular structure. Otherwise called also, you can call it as like a pyramid shape. So it has got three edges: apical process, vocal process, and muscular process, and it articulates with the cricoid and forms a cricoarytenoid joint. It's a very important thing that is happening. That is the posterior point. That is why it is articulating. What are the causes of injury to arytenoid cartilage, and what will be the effect of that? What will happen to the? How will it manifest clinically? Causes of injury are protrusion of an endotracheal stylet. When you use stylet for intubating the endotracheal tube, and if the stylet projects outside the endotracheal tube, you must be very specific that it is within the end of the tube, that is the beveled end of the tube. It should not project beyond that. And it may be when you use a gum elastic bougie for difficult intubation or blind intubation techniques using a light band or a stylet, or insertion of bulky double lumen tubes. In all these incidences, it's a chance that arytenoid cartilage can be injured. Other preconditions which may also lead to arytenoid cartilage injury are chronic corticosteroid usage. For example, patients with bronchial asthma who have been using corticosteroids for long, both oral and inhalational, or patients who have laryngomalacia, or patients who have acromegaly, or obese patients with a higher BMI, they also run the risk of injury to arytenoid cartilage because of difficulty in intubation. And when you use transesophageal echocardiography, there again you have to be very, very gentle not to injure the arytenoid cartilage, because this is more bound to happen when you use a larger scope like a transesophageal echocardiography. And the clinical effects will be patient will develop hoarseness of voice, or they may have difficulty in swallowing, and they will have pain in the anterior region of the neck. So whenever a patient complains of persistent pain after post-intubation, the post-operative period for 2-3 days, don't ignore it. Always have a look at the arytenoid cartilage by indirect laryngoscopy using the mirror, then you can see the improper movement of the arytenoid cartilage. What are the muscles? Now we have seen all the applied anatomy of the cartilaginous framework of larynx. Now the muscles of the larynx, which and their action and their muscle nerve supply. It's the next part we have to know. Can you name the muscles of the larynx?
Cricothyroid, cricoarytenoid.
So you have to classify them by their actions. You have adductors of vocal cord. You have muscles are all acting only on the vocal cord. Okay, or you can classify them as suprahyoid and infrahyoid muscles. That is another better way of classifying the muscles. So you have some muscles which are attached above the hyoid bone to the laryngeal structure, and you have all the muscles which are acting on the vocal cord level at the below the hyoid bone. So you can classify them as suprahyoid and infrahyoid muscles. Can you name some of the suprahyoid muscles? All the muscles which are above the hyoid bone. Where will they be attached to?
Stylohyoid,
styloid process, mandible. Okay, so divided into extrinsic and intrinsic muscles. Extrinsic muscles can be further divided into suprahyoid muscles, which are stylohyoid, geniohyoid, mylohyoid, thyrohyoid, digastric, and staphylophryngous. And their main function is to elevate the larynx. Whenever you turn your neck or extend your neck, these muscles are the ones which also pull the larynx along with that. And the infrahyoid muscles are omohyoid, sternothyroid, sternomentoid, thyrohyoid, which lower the larynx. So to counteract the elevation, you have muscles which can lower the larynx. And the intrinsic muscles are the ones which control the vocal cord functions. And they can be classified into adductors, abductors, and tensors of the vocal cord. Okay. So this handwritten picture will tell you the names of the intrinsic muscles and their actions and their nerve supply. If you remember this picture, it will be easy for you to draw in the examination. So you have AB means abductor. This is the action that is given here. So it moves away. Red marking AB, both the sides. When will the vocal cord abduct? Which part of the respiratory function it has to abduct? God, this is when should the vocal cords separate and abduct?
Sir, during inspiration, sir.
Inspiration.
Yes, sir.
I got confused because of the way it is asked, is it? So during inspiration, it has to separate and it has to collapse or come back to normal after inspiration. Okay, so that is the adduction. So these are the two main functions, abduction and adduction. And while you speak or phonate, this has to relax and tighten. That is called tensor. Okay, so three actions: abductions, adduction, and tensor. So the only abductor you have is the posterior cricoarytenoid. There is only one muscle to separate the vocal cords during inspiration or any deep inspiratory effort. All the four muscles are there to cause adduction only, that bring back the vocal cords to the midline or close the vocal space on the glottic opening. And there are two tensors which are mainly useful during phonation. Okay, so 1 plus 4, 5 plus 2, 7 muscles are there in the intrinsic muscles group. And the nerve supply, all of them except the cricothyroid muscle, okay, which is the adductor as well as the tensor muscle, that is supplied by the word S. What does it stand for?
Superior laryngeal nerve.
Superior laryngeal nerve, external branch of superior laryngeal nerve. All the other muscles are supplied by R.
Recurrent laryngeal nerve.
Recurrent laryngeal nerve, right and left recurrent laryngeal nerve. Okay, so only muscle supplied by superior laryngeal nerve, external branch is cricothyroid. All the other muscles are supplied by recurrent laryngeal nerve. So you have three groups of muscles: abductors, only muscle abductor, cricoarytenoid, posterior cricoarytenoid, and 4 adductors and 2 tensors as well as part of adduction also cricothyroid. Okay, so that can be remembered by the mnemonic. For posterior to clit, you see a valley. This is the mnemonic to remember. So the posterior is an abductor, that is the posterior cricothyroid. The red or pen, if you see abductor, and all the green letters is the adductor, is the clit. Cricothyroid, lateral cricoarytenoid, interarytenoid, and thyroarytenoid. Now you see the importance of arytenoid, how many intrinsic muscles are attached to the arytenoid, and that is the reason why you have to be very careful in not injuring that. If you injure that, all these muscles will lose their action. So you have lateral cricoarytenoid, interarytenoid, and thyroarytenoid. So the muscles are getting attached to both the arytenoid as well as the cricoid cartilage, arytenoid and thyroid cartilage, and in between because it's a paired cartilage, there is attachment between the two itself. And the tensor or mucalis muscle is a muscle which is a part of the thyroarytenoid also. So you have tensors acting, which are also part of the adductors only. So this is the nerve supply and muscles that you have to remember. And what is unique about the posterior cricoarytenoid, which is the only abductor? Is there any unique characteristic of this only abductor which is separating the vocal cords? So that is the only abductor The origin is posterior surface of cricoid lamina, which we saw in the posterior larger lamina is the area from where the muscle, that is why you have that larger surface. I asked you the question why the anterior arch is smaller and the posterior lamina is bigger, because the muscle has to take origin from the lamina. And the insertion of muscular process of arytenoid is also taking place, and action vocal cord is abduction, and it is supplied by recurrent laryngeal nerve. So any recurrent laryngeal nerve injury, the first action to go will be the action of posterior cricoarytenoid or abduction. So if the abductor is paralyzed or not acting, what will happen to the vocal cords? Which muscle will be still acting? The abductor is not acting, which is the muscle still acting?
Yes.
Adductors. So what will happen to the vocal cord? Will it come to the midline or go away from the midline?
Come to midline, sir.
Midline.
Paramedian. Yes.
When it's either midline or paramedian. So what will happen to the glottic opening? Will it become narrow or larger?
Narrow, sir.
Narrow. So will it cause more difficulty in breathing or happy breathing will be there?
Difficulty in breathing. sir.
Difficulty in breathing. Especially if there is bilateral partial recurrent laryngeal nerve injury, then both the abductors will be paralyzed and only adductors will be acting. And what will happen at that stage? Supposing during thyroid surgery, surgeon is very heroic, total thyroidectomy, he has damaged both the recurrent laryngeal nerves, but they are not fully cut, they are partially injured. And any partial injury, the first muscle to be paralyzed will be the abductor, posterior cricoarytenoid. So what will happen when you extubate?
Stridor, hoarseness. and
Complete
stridor.
inability to breathe, because both the adductors will come to the midline and it will completely close the glottic opening. And that is the reason why nowadays we have methods to assess the damage of the recurrent laryngeal nerve intraoperatively by using endotracheal tubes which have nerve stimulator attached to that. Okay, so nowadays we have gone to that level to prevent the recurrent laryngeal nerve injury. So this question is very commonly asked in the examination. What happens in partial recurrent laryngeal nerve palsy? Which muscles control the pitch of the voice and the intensity of the voice? For that, the answer is recurrent laryngeal palsy. If it is one-sided partially, the vocal cord adductors will be acting. So the vocal cord will come towards the midline, median or paramedian position due to overactivity of the adductors, cricothyroid muscle, this muscle. And the pitch of your voice is mainly controlled by cricothyroid because they are the tensors and vocalis. These two muscles are important for any alteration in our voice. The pitch or intensity is mainly by this, the pitch and the tone is mainly by the tensors. And intensity of the voice is mainly by the expiratory effort of subglottic pressure. Okay, so these are all the points that we have to know about how the voice and which part of the anatomy comprises of supraglottic area. Commonly we use this term supraglottis. It connects the larynx to the base of the tongue. Okay, and extends up to a portion called ventricle. It can be subdivided into epiglottis, aryepiglottic fold, arytenoid, false cord, ventricle. And it is lined by stratified squamous epithelium, and it has a rich lymphatics which is through that, and it meets at the jugulodigastric nodes or through the cervical nodes. And this lymphatic is the main carrier of any cancer spread from the laryngeal cancer spread through this lymphatics. And what is the difference between the adult and pediatric epiglottis? This picture was given in the last practical exam OSCE for the students who just completed their exam last month. And this picture was given and they were asked to identify this. So you can see the epiglottis of the adult as well as the pediatric patients. Can you now, after seeing this, tell me what are the differences
Shaped
between
epiglottis in pediatric.
Omega shaped
Omega
and
shaped
U-shaped
of the
epiglottis.
Omega shape? Which one? Pediatric or adult?
Pediatrics. Pediatric.
Adult is a
Leaf-like shape.
leaf-like or U-shape. Very good. Number one. Then the questions that were asked in the OSCE after showing this is, what is the shape of the pediatric, what is shown here, number one, what is the shape described as, what is the importance of this, what will you do when you do an intubation in this case? What to do, what is the difference between an intubating an adult and a pediatric patient with these two different epiglottis like this?
In pediatric, we use a Miller blade so that we lift the epiglottis along.
You include the epiglottis also when
Yes, sir.
to view the opening, okay? Whereas in adult, you stop short before the epiglottis.
Vallecula.
It's called vallecula, okay? And lift the epiglottis. So you can always see a picture like this only when you intubate. Whereas when you intubate, you will see only a straight hole, not the epiglottis in pediatric patients, okay? But anatomical differences are omega shaped and U shaped or leaf shaped in the adult, and it is located higher in the throat. That is highly placed, as we saw, the entire larynx is at a higher level, and it has a steeper angle up to the trachea compared to the adult. And the third point is, it is more pliable and floppy due to immature cartilage, and it is prone to collapse during breathing. Okay? That is the important difference. And anatomy and function of airy epiglottic fold is another area which we have to know. So this picture sometimes can be asked. So here what you see as a pearly white structure is the true vocal cords. Okay? And you can see the epiglottis is here, the tracheal opening is there, and this is the airy airy epiglottic fold. That is the attachment of arytenoid cartilage to the epiglottis. This is done by a covering, and within this airy epiglottic fold only you have the corniculate and cuneiform cartilages. So when you do a scopy here, you can see this. This is the corniculate and cuneiform bulging, which you are seeing in the live picture. You know, this is a drawing. This is a true picture of a live specimen. So these bulges are the cartilages which are formed here, and they are almost like vestigious. So airy epiglottic fold extends from the arytenoid to the epiglottis, contains the corniculate and cuneiform cartilage. When it is become flabby, it can cause laryngomalacia. The causes of, we have heard about tracheomalacia, so due to constant erosion by a huge thyroid on the outside, the tracheal cartilages will become softer, and once you extubate, the patient will have a collapse. So the obstruction occurring in tracheomalacia is lower down. But if the airy epiglottic fold is also affected, and that's why I told you about chronic usage of corticosteroids, this laryngeal airy epiglottic fold will become very lax and flabby, and that will cause a laryngeal obstruction by causing laryngomalacia. And they also have three sphincters during pharyngeal phase of swallowing. The importance of airy epiglottic fold is it has to close properly to prevent aspiration. So during swallowing, all the three structures, airy epiglottic fold, false vocal cords and true vocal cords, all of them will close to prevent aspiration into the lower respiratory tract. Now, after the supraglottis, we should also know about the glottic opening. So it comprises of two cords, which I showed you, the pearly white structure, and it is almost like a triangle, and it has an anterior commissure and a posterior commissure. And the middle opening is called rima glottis, the triangular space between the two vocal cords, and it is about 1 centimeter below the free margin of vocal cords. There is the narrowest part in the adult larynx. So this is the picture that you can see here. This is the two vocal cords, and they have the vocal folds, these side curtain-like things. This is the epiglottis. This is the airy epiglottic fold with the corniculate and the cuneiform cartilages inside. So this center opening is called the rima glottis, or the gap between the two vocal cords. So what is the true vocal cord? Where is the true attachment of the true vocal cord, and what is its structure? So true vocal cords are, their anterior 2/3 is made by membranous vocal ligament and muscle. And posterior 1/3 is by vocal process of arytenoid cartilage. And vocal cord inserted into the midline of thyroid cartilage on the anterior aspect via the Broyles ligament. And at the level of insertion, inner perichondrium is absent, and Broyles ligament limits the inferior spread of glottic cancer. So, glottis, if you develop a vocal cord cancer, it will not spread below that level because of the absence of perichondrium and the ligament that is present there. So, this is the anterior commissure, which is the narrow part. Posterior commissure is wide enough, and this anterior 2/3 is membranous, and the posterior 1/3 is because it's attached to the arytenoid, it is cartilaginous part. Okay, so this is the structure that sometimes you may have to, they may be asking you. And the extent of, so we saw supraglottis, we saw the glottis, which is the opening, then you have a subglottic area. So subglottic narrowing and occlusion is a very common term that all of you would have heard about. In whom it is more common? Subglottic stenosis or narrowing or occlusion, in which patients it's common, adult or pediatric? All of you would have read about the differences in the anatomy of the respiratory tract between adult and children, isn't it? Okay, so subglottic area extends up to the lower border of trichid cartilage. So from the epiglottis, below that you have the vocal cords and rhinoglottis. Then below the rhinoglottis is the subglottic area. It is from the glottic opening to the trichid cartilage is called the subglottic region. And it has a mobile upper part below the vocal process of upper border of trichid cartilage and a fixed lower part. It extends up to the inferior part of the trichid cartilage. Okay, so this is the vestibule. This picture will tell you an idea about the infraglottic or subglottic space. And this is the trichid cartilage, which has been cut and the thing has been opened. So after entering the vocal cord gap or the rhinoglottis, in the adult, this is a very large area. Whereas in the pediatric patient, this opening will be slightly larger, whereas the subglottic area will be narrower. Okay, you can see the difference here. This picture will tell you the anatomy of the subglottic region in the adult. It is like a uniform cylindrical tube in the adult. Whereas in pediatric patients, it's funnel shaped. It has a larger opening at the top and it becomes narrower. So any intubation with a larger size tube or use of a soft endotracheal tube for a long time, all that can cause an obstruction at the cricoid ring level, okay, because that is the narrowest part. And that is why it is called subglottic stenosis. Glottic opening, below that is subglottic area. So subglottic narrowing or occlusion is very common in pediatric patients. So that is always the teaching you have is whenever you intubate a pediatric patient, especially children below the age of 10 years, always use a tube which may have a slight leak. You should not put in a very tight fitting tube there. And an audible leak is always acceptable in pediatric anesthesia. That is the dictum. When you put a tube which is, if you have some leaky sound around the trachea and the tube, that is acceptable because that will not cause subglottic edema and narrowing after extubation. So this is a common question they will ask in the examination. So it is funnel shaped and cylindrical shape in the adult and the pediatric patient. So subglottic stenosis occurs in pediatric patient. Why? And upper half of stenosis is difficult to treat. Why? So these are the two reasons I told you. Subglottic area is divided into a mobile upper part and a fixed lower part. So the answer for that is subglottic stenosis more common because of non-expansile ring this age. And lower half is dealt by, whereas if you have a lower half problem, it can be removed by resection and anastomosis, whereas upper half is difficult to treat because arytenoid is always attached to that. As we saw here, they have the arytenoid the folds are there, area epiglottic fold, so that will prevent the excision of the upper half of the glottic cancers. Now, coming to the nerve supply, we have seen that all the importance of the various cartilages and their applied anatomy. Now we have to go to the origin and divisions of the two nerves which supply the larynx. One is the superior laryngeal nerve, another is the recurrent laryngeal nerve. So, where does the origin and what are the divisions of superior laryngeal nerve? Where does it arise from? Are there branches of any cranial nerve? Vagus.
Vagus. Yes, sir.
I think none of you have made any effort to read about all these things. Superior laryngeal nerve separates from the vagus just outside the jugular foramen, okay, at the inferior vagus ganglia. And at the level of hyoid bone, it divides into an internal and external branch. And as I told you earlier, what does this external branch supply?
So, cricothyroid.
Trichothyroid muscle. Okay, just now we saw in the earlier slide. Only muscle supplied by this is the external. All the others are supplied by superior laryngeal nerve, recurrent laryngeal nerve. So, what are the functions of the internal and external branches of superior laryngeal nerve? It divides into two branches we see. And what is the clinical importance?
It supplies sensation above the vocal cords.
Above the vocal cords, fantastic.
Yes.
The internal branch passes through the thyroid membrane and sensory innervation to the vocal cords and above the vocal cords. And the branch can be blocked from outside by injecting LA drug through the thyroid membrane. Okay. So the external branch supplies the only muscle, trichothyroid. Trichothyroid is the muscle supplied by the external branch. What is the course of recurrent laryngeal nerve, which is the other major nerve supplying almost all the muscles, intrinsic muscles of the larynx? And what is the clinical importance?
The left recurrent laryngeal arches along the arch of aorta. It's,
Both sides?
Left alone, so left recurrent.
Left,
laryngeal.
right?
And right around the subclavian.
Subclavian, fantastic. So the recurrent laryngeal branches from again vagus only in the thorax, whereas here it is from the jugular foramen as soon as it comes out of the skull. So the recurrent laryngeal separates at the level of the thorax from the vagus, loops around the arch of the aorta on the left side and subclavian artery on the right side before traveling back. That is why as it returns and go back, it is called recurrent laryngeal nerve. Even though it is supplying the larynx, it doesn't come and straight supply like that. It descends down below the level, then curves back and goes. That is why it is called the recurrent laryngeal nerve, traveling back between the esophagus and trachea to supply all the intrinsic muscles except trichothyroid. And also it has a sensory branch to supply the sensation below the vocal cord. So internal branch of superior laryngeal nerve supplies the sensation above the vocal cords. The recurrent laryngeal nerve supplies the sensation below the vocal cord. So whenever you want to do an awake intubation by blocking these nerves, you can block them by piercing the thyroid membrane outside. I'm going to show you a picture how to do that later. And how will you block the recurrent laryngeal nerve below the vocal cords? What is the technique that you can use? Okay, we will see that.
Okay.
Transtracheal, fantastic. So Ortner's syndrome is the hoarseness of voice due to compression of the recurrent laryngeal nerve caused by mechanical compression, which in mitral stenosis is one of the important complications of the left atrial enlargement. And what is Simon's law?
The outer fibers are affected first, that is abductors are affected first.
Fantastic. So abductors, which we saw, only abductor is there. Posterior cricothyroid, which is the, cricoarytenoid, which is the only abductor of the vocal cord. And phylogenetically, that is during the evaluation, this muscle got developed later. So creatures which were there before during the evolution, they all had only adductors, no abductors. So the muscle which became originated later phylogenetically, it was more easily damaged or affected whenever there is an injury to sacroiliacal nerve. So that is what is the Simon's law saying. So abductors will be affected first before the adductors. So it's a progressive lesion of sacroiliacal nerve. Abductors are paralyzed before the adductors. So there is always a risk of the glottic opening becoming narrower or totally closed down. So this means in incomplete paralysis, cord will be brought to the midline by the adductors, and in complete paralysis, it will fall away from the paramedian position also. And if it is a unilateral damage, then the contralateral cord can partially compensate for the opening. So that will cause a little excess opening to maintain. So patient will not feel much of a problem in partial injury on only one side. But if it is a bilateral partial injury, it's a very grave emergency situation where both the adductors will come to the midline and glottic opening will be totally closed. Unless you paralyze them and intubate the patient again and plan for a tracheostomy, the survival will be very, very difficult. Now comes the next part of the anatomy. What is the blood supply to the larynx? Again, we'll go a little quickly because already some external branches from external carotid gives the superior and inferior thyroid arteries, and which again give the superior and inferior laryngeal arteries. And subclavian artery also supplies the larynx, and venous drainage, superior laryngeal vein, middle thyroid vein provide the venous drainage. Lymphatic drainage above the vocal cord, it is going to the deep cervical nodes. Below the vocal cord, it goes to lower deep cervical, and the vocal folds, they have no lymphatic drainage. And what is trichothyrotomy? Why is it safe? This picture also was the procedure of trichothyrotomy was also there in the OSCE in the last exam. So what is cricothyrotomy?
It's making a small opening in the cricothyroid membrane, sir.
Cricothyroid membrane, fantastic. When it is done?
For Fona technique, and a difficult.
Very good. Difficult. When you cannot intubate, cannot ventilate, then final savior is the front of neck axis, Fona, that's what you mentioned. And why it is safe? Why you choose this particular membrane?
It's avascular, sir.
It is avascular structure. Fantastic. The cricothyrotomy is an opening made by a slit or a small hole, and it is relatively avascular cricothyroid membrane. Can you attempt cricothyrotomy in children? It has been described. You should not do it because the children, the membrane is not well developed, so you can damage the cricoid cartilage or thyroid cartilage. So cricothyrotomy is not advocated in children, and this is just for you to see and remember how a cricothyrotomy is done. So this is the thyroid cartilage, this is the cricoid cartilage, and in between you have the cricothyroid membrane. So you can first put in a needle, and once you enter the lumen of the trachea, the larynx, you can aspirate free air, and then you can either use a Seldinger technique by putting a guide wire and then expanding the opening, and then through the guide wire you can introduce the thyrotomy tube. You know the name of this technique? Okay, this is called the Melker percutaneous cricothyrotomy. Okay, it's called Melker percutaneous cricothyrotomy. Now this is a picture to remember the nerve supply. You have the internal laryngeal nerve going, superior branch comes, superior laryngeal comes here, it goes to the internal to supply the sensation above the vocal cord, internal laryngeal going out. This is the external laryngeal going to supply the cricothyroid muscle, and you have the recurrent laryngeal nerve coming, which supplies both sensation below the vocal cord and all the other muscles of the intrinsic muscles. And blood supply comes from superior laryngeal, which is a branch of thyroid, superior thyroid, and inferior laryngeal coming from an inferior thyroid artery. And lymphatic drainage. What is the clinical application of anatomy of larynx for us? Here you can use it while doing direct laryngoscopy. You have to use a laryngeal mirror before you. ENT surgeons, all of you would have known that they were using this mirror to assess the vocal cord function, structure, how it is moving. So earlier days we used to do this, send the patient to the ENT surgeon for documentation of the movement of vocal cords before any thyroid surgery is planned, so that you can identify if there is a existing vocal cord palsy or it happened after surgery. Another thing is this is called the nasal endoscopy, which has become more common than doing this older technique of using the mirror and seeing the vocal cord. So you can put a scope which is a shorter length, like unlike your fiber optic scope, and you can witness the movement of the vocal cords. So this is the more preferred position or technique for assessing the vocal cord function before thyroid surgery. And all of you are aware that we do direct laryngoscopy to visualize the cords before intubation. So that is another reason why you should have a good knowledge of the anatomy of the thyroid. And what is laryngospasm? This is one of the clinical complications that can happen under anesthesia. What exactly happens? How is it classified? The sustained closure of vocal cords resulting in either partial or complete loss of patient's airway. Okay, so that classification is either partial laryngospasm or complete laryngospasm. So in complete laryngospasm, the vocal cords are completely occluded. Just like your partial injury to recurrent laryngeal on both sides, you will have a complete closure of vocal cords. Whereas the partial is, there is still some opening, but the opening is very small, the patient will struggle to breathe through that. So causes, what are the causes of laryngospasm under anesthesia? After, have you all of you had a chance to see this complication?
Yes, sir.
Yes, sir. No. Without seeing this, no one can qualify. At some stage of our training, sometimes we have seen. So the causes are inadequate depth, airway irritation, irritant anesthetic gases, instrumentation in a lighter plane, and patient factors, recent URI, smoking, anxiety, asthma patients, they are all likely to have that. Which muscles are involved in laryngospasm? We have seen what are the muscles, the intrinsic muscles like lateral cricoarytenoid, thyroarytenoid, which are glottic adductors, and cricoarytenoid and vocal SSL, which are tensors. Okay, so only it has to close, so only adductors and the tensors have to act. The only abductor is posterior cricoarytenoid, that cannot act. So all the other adductors have to act. So you just remember that it is the cricoarytenoid and thyroarytenoid, which are all the adductors which have to act, and also the tensors will act. So how do you manage laryngospasm? This is one of the very, very common questions in practical examination.
Sir, remove the stimulus.
Very good.
Fantastic. Yeah. To relieve a spasm, we can give a Larson's maneuver or give a propofol to relieve the spasm or positive pressure. If it is not possible, we can give a small dose of succinyl choline and
very good, very good, very good. Can be divided into prevention and treatment. So prevention is identify patients at risk. You can administer magnesium sulfate prior to extubation or lignocaine, just like you do it during induction before intubation to prevent the stimulation response of laryngoscopy in intubation. You can do this also before extubation, and you can give atropine to prevent this problem in children. And the treatment part is removing any triggering stimulation, clear larynx of blood or stomach content, application of CPAP with 100% oxygen, relieving any possible supraglottic component of the airway obstruction, and IV propofol, not the usual induction dose, but only 0.5 milligram per kg, And if all these maneuvers are not relieving that, you go for succinyl schooling at the dose of 0.1 to 0.2 milligram per kg, not the usual 1 to 2 milligram. Only 0.1 to actually 0.12 should be the thing, the return type. And Larson's maneuver has been described, but the efficacy of that has been questioned in various journals and the textbooks. But you have to mention this in your answer in the examination, which is a bilateral firm digital pressure on the styloid process behind the posterior ramus of the mandible. And it's a vigorous jaw thrust that will press between the posterior ramus and the anterior mastoid process, which is more like an effective jaw thrust. Okay, and superior laryngeal nerve blocks also have been described for that to abolish the sensation. And what is Brewer-Lacard syndrome or reflex? Have you heard of this name?
No, sir.
This is another condition where any stretching of the cavities in the body, like anal stretching or cervical dilatation during DNC to do a curettage of the uterus, these things in a lighter plane of anesthesia can result in severe laryngospasm. Okay, so laryngospasm and body muscle movement can occur during stretching or of anus during what the procedure called maximum anal dilatation, which is done for curing fissure in the nose. And the cervical dilatation during DNC procedures. So all of you remember, usually these things are told that you can do it as a very short procedure, you can do it under just mask ventilation, but never take it lightly. This complication, if it happens, it can be life-threatening. So lighter plane of anesthesia should not be allowed during this procedure. So you ask the surgeon to wait till you make sure that the plane of anesthesia is quite big enough to proceed with this. And this picture, what is being done here? This is thyroid cartilage, this is the hyoid cartilage, this is the cricoid cartilage. And a needle is being inserted between the thyroid and the cricoid. So what is being done here?
Cricothyroid.
It's a cricothyroid puncture to the syringe is containing some liquid.
Is transtracheal.
Transtracheal analgesia. LA during by puncturing the cricothyroid membrane. This is done for fiber optic intubation or awake mesotracheal intubation. We have to do this to anesthetize the trachea below the vocal cords. Okay, for it is done to anesthetize the area below the vocal cord in awake intubation. Now, what is this? You can see this is a hyoid bone. The operator is holding the hyoid bone and needle is being inserted close to the hyoid bone. And this is the tracheal thyroid cartilage. So this is the thyrohyoid membrane, internal branch of the superior laryngeal nerve being blocked by landmark technique. So he is holding the hyoid bone, pushing it to one side. First go and hit the hyoid bone, then slide the needle below so that you will puncture the membrane between the hyoid and the thyroid. So inferior border of hyoid and superior border of thyroid, you have the thyrohyoid membrane. So first you can hit the bone, then slide the needle down, and once you come to the lower end of hyoid, you inject about 2 ml, you will block the branch which is piercing and going inside to supply the area above the vocal cords. Okay? Palpate the hyoid bone using thumb and index finger, push it to one side to make it prominent, insert the syringe with a 23 gauge needle, hit the hyoid bone and slide it down till the needle pierces the thyrohyoid membrane, inject 2 ml. Repeat the same thing on the opposite side. If you do that, you will have perfect analgesia of the glottic opening. So patient will not go into laryngospasm, or you will not feel the tube entering, and the cooperation will be very, very good if you are able to do this block successfully and as well as this block. Right. So that is about indicated in awake intubation. So that completes the anatomy of larynx. So we have completed the nose, we have completed the larynx. Now we are going further down. So the next part is the bronchopulmonary segments. How many bronchopulmonary segments are there? So this is the picture. So this is the larynx, this is the cricoid. So the larynx ends with the level of the cricoid. After that, the trachea starts the tracheobronchial tree or the bronchopulmonary segments. Okay. So the usual question they ask you is about the tracheobronchial tree or bronchopulmonary segments, whichever wording is given, it all indicates the knowledge of these things only. So trachea is there, anatomy of trachea, all of you should know. And then as it divides, this is called the Weibel's classification of tracheobronchial tree. How many generations are there? The divisions. All generations. You can see the G. So
23.
trachea is it divides into two, each one divides like that. Ultimately, you have 23 generations or divisions. Okay, and up to 16, and this is called the conducting zone, where the air only travels in and out. So they are called conducting zone, and their structure and their lining mucosa are all different. And between 17 to 19 or 20, it is called transitional zone, where slightly some gas exchange will take place, but mostly it will be again a traveling of the gases. But below 20 or 21, it is purely the gas exchange zone. It is called alveolar zone or respiratory zone. Okay, so they are alveolar ducts and alveolar sacs. So this knowledge will tell you where exactly the gas exchange of taking in the oxygen and removal of carbon dioxide is happening, and all other areas are only conduction zones where the gas is simply traveling in and out. Now, the tracheobronchial tree, the branching tree of air spaces. First of all, it is made up of trachea, starting point. Then it divides into the various bronchi, lobar bronchi, the segmental bronchi, and then the bronchioles, which is the ultimate smallest part of the conducting passage. So it has branching up to 23 branches or generations made described by Weibel. And what are the characteristics of the trachea? What is the length of the trachea in an adult? So it is about, you must know the comparison at what level. It starts from the C6 cervical vertebra and extends up to the carina. It is called the trachea, because at carina level it divides into the right major bronchus and left major bronchus. And the T4 and T5, it bifurcates. And one second, sorry. With you. Can I call you? I am in class. I will call you. So this is the length extension of the trachea. It is about 12 centimeters long in an adult, and it has a diameter of 24 to 26 millimeters, not centimeters, and it is a slightly lesser diameter in female. And at the level of sternal angle, it bifurcates into right and left main bronchi, and the trachea has a C-shaped cartilage. Why there is a C-shaped cartilage? It is not a complete ring. What is the reason for that? What is the structure behind the trachea?
Trachealis muscle.
Trachealis muscle is part of the trachea. Behind the trachea,
Esophagus.
esophagus. So when you eat food, if you have a complete cartilaginous ring, what will happen? The food travels down. Every time you will feel as though you are obstructed. So the swallowing will be difficult, isn't it?
Yes,
So
sir.
nature has made it such a beautiful way that there is no hard cartilaginous ring on the posterior half. Instead, it is filled with the trachealis muscle, soft muscle. You will see later in the picture. So the posterior wall of trachea is formed by the trachealis smooth muscle, and it is made up of 16 to 20 hyaline cartilages rings. So it is not constant, it may vary from person to person, connected by annular ligament. And the cartilaginous rings are responsible for keeping the trachea open in spite of the intrathoracic pressure occurring during the respiration. Okay. Now this is the trachealis muscle which you are seeing here. Okay. So here you have the esophagus. Now this picture will tell you why the cartilage is deficient here. Okay. And because of the, we have to swallow food without difficulty, this ring is deficient here. And this is the trachealis muscle which keeps it open all the time. Okay. So if this muscle is not there, the cartilage will collapse. So it is also acting like a scaffolding for keeping the trachea open. And these are the pictures which we wanted to show. Anatomy of the bronchi is very important. It starts at the level of the P5 and the trachea bifurcates. And the right main is very short. This is very important when you do one lung ventilation, because the right main bronchus is a shorter one than the compared to the left main. So we always prefer to put the W1 tube in the left main bronchus than the right main bronchus, because the right main bronchus not only short, the upper lobe bronchus going to the upper lobe will take origin very soon after the division. So by pushing the tube to the 2.5 centimeter length, you will invariably occlude the opening of the upper lobe, which will collapse. So that is the reason why we always prefer to use the left side rather than on the right side. And the secondary bronchi, 3 on the right, that is going to be 3 lobes on the right side, upper lobe, middle lobe, and lower lobe. They are called the secondary bronchi. And on the left side, because you have only 2 lobes, upper and lower, you have 2 main bronchi. And each secondary bronchi, once they go into the lobe, they divide into tertiary bronchi, which supply the so-called bronchopulmonary segments. And the segmental bronchi undergo further branching to form numerous small airways called the bronchioles. So this is how the whole thing is dividing into various categories. And the bronchioles, they also are passages without any cartilage. They don't have cartilage and they are more made up of smooth muscles. So if at all a bronchospasm has to happen, where should it happen? It should happen only in the bronchiole level, because all other areas you have the cartilage. Okay. So bronchioles initially divide into many generations of conducting bronchioles, which further divide into terminal bronchioles and respiratory bronchioles, which I showed you in the very first picture. And the bronchioles are lined by simple cuboidal ciliated epithelium, and they have no hyaline cartilage or submucosal glands, but are surrounded by elastic fibers and smooth fibers, muscle fibers. So there is a club cell in major cell type in the epithelium of the bronchioles. These club cells are protein secreting non-ciliated cells and short microvilli that produce anti-inflammatory and immunomodulatory proteins and cytochrome P450 enzymes and play a role in detoxification. We will be seeing later what are the non-respiratory functions of the lung, which one of the things I showed you in the subdivision of physiology. So the detoxification function is done at this level. Now name the segments of the various lobes of the bronchopulmonary segments. That is one of the common questions that is asked. How many segments are there in the upper lobe on the right side and left side?
3 and
3. Middle on the right side?
2, sir.
2. Lower?
3 or 4, sir. 4. 4.
Lower lobe has 5. So right side you have 10 segments. Upper lobe 3, middle lobe 2, lower lobe 5. On the contrary, left side you have only 2 lobes, upper and lower. And again upper has got 3 like right lobe and lower has 5 like the lower lobe. And there is a lingula, which is a representative of the middle lobe. So you have 9 bronchopulmonary segments on the left lobe. So you have total of 10 plus 9, 19 segments. Okay. So this is the picture that you have to remember. So this is the right bronchus, which is very short, 2.5 centimeters, and you can see the upper lobe bronchus taking origin the very short distance, and the left lobe is longer. Left lobe main bronchus is the 5 centimeters, and again the upper lobe is taking off here, and then you have the middle lobe going. There's a lower lobe main bronchus dividing into all the branches, and the segments of the lung are contaminated during aspiration in various postures. That is the common question they will ask you in the exam. So if a patient is sitting, the patient is lying, the patient is in prone, if the patient is in lateral posture, which particular segments of the lung can have an aspiration problem? That is a common question. So in the supine position, which one do you think will get contaminated if the patient does not have a proper cough reflex, especially ICU patients, and you give a oral feed and they aspirate? Which portion of the lung will be contaminated with the aspirate? In the supine position, apical segments of the lower lobe. See, this is the lower lobe. You can see the apical segments which are going directly posterior. Okay, so when the fluid comes here, it will travel and go and get deposited in the apical segments of the lower lobe. Both the lower lobes can be affected, and because they project directly posterior from the lower lobe, lower bronchi, in sitting position, just looking at the picture, can you just make a guess, even if you are not aware of what is actually happening? Right. It is the posterior basal and lateral basal. Okay. So this is the lateral basal and this is the posterior basal segment. So these two segments. So lying down, this posterior apical branches of the posterior lower lobe will be affected. And in the sitting, it will be the same lower lobe, but the lateral basal and the posterior basal segments of the lower lobe will be affected. And because they also project downward. And in the lateral position, the upper lobe bronchus on the dependent side. You can see that when the patient is lateral, you can see that this will be the easy access. So upper lobe, they project laterally, and in prone position, middle lobe on the right and lingula on the left. So these are all the areas. So supine position and sitting position, it will be mostly basal, that is the lower lobe. Lateral, it will be the upper lobe, and prone, it will be the middle lobe. So just remember like that, even if you don't remember the segment. And what is the predicted postoperative respiratory function? How is it done using the segments? Another important practical application of this, knowing about the bronchopulmonary segments, is I told you you have 10 on the right and 9 on the left. So you can calculate the patient's efficacy to have a normal respiratory function after a lobectomy or a pneumonectomy is by estimating the postoperative FEV1 and FEC and diffusion capacity. These three parameters are taken into account, especially when you want to do a large volume of the lung. So the formula that you have to use is, for example, if you want to do a right upper lobectomy, you know that there are three segments: apical, posterior, and the anterior. These three segments will be removed. And a patient with a FEV1 of 1.6 liters in the preoperative phase, which is about 8% of the predicted FEV ratio. Then once you remove the three segments, a patient will be left with 16 segments only. So 16 by 19 multiplied by 1.56, you can get a value of 1.35 liters. That will be the post-operative FEV, it is post-expiratory volume. And if you make a ratio of that, it will reduce from 80% to 67%. Okay, so that you can calculate this in the pre-anesthetic phase itself and decide whether he will be requiring any assistance in the post-operative phase. So these are the two important applications of the bronchopulmonary segment. One is which particular lobes will be affected by aspiration. The second thing is how much of safe removal of the affected lung you can do in the patient to see whether he can survive postoperatively without any difficulty. Now, another practical use of this bronchopulmonary segments is if a patient is in ICU and has been on a ventilator and in the recovering phase, nowadays you can just say ask the physiotherapist to come and do chest physiotherapy, but you should also have some knowledge about how to do the physiotherapy in various positions for clearing the various segments of the lung which are affected. So this picture tells you about the positions of the various so position for patient for postural drainage, and for the right middle lobe, supposing they ask you right middle lobe, which position I told you will be affected by, will affect the right middle lobe, supine, sitting, or lateral, or
Prone, sir.
prone. Huh?
Prone, sir.
Prone. We saw prone is the
Middle lobe.
middle lobe. So that is the one which will be affected. So patient, if you see the middle lobe, here this is the picture of the middle lobe. So you can see patient is slightly head down about 30 degrees. He is in the lateral position, and the upper limbs are raised and the chest is exposed, and you start tapping here, then you can clear all the secretions in the middle lobe. So right upper limb elevated and above the head, and both knees are slightly flexed, and this is the bronchoscopic view of the trachea, the carina, the right main bronchus, left main bronchus. So the right main bronchus, you can see the opening of the upper lobe bronchus origin very soon after you enter. Okay? So this is a picture to give you some idea about it. Now, after the bronchopulmonary segments and their application, now we come to the last part of the anatomy, the diaphragm. So this is also another question which is repeatedly asked in the examination. So, any idea about diaphragm? What is it made up of? So it is a Greek word. It is a through fence. Pragma means so it is forming a fence between the thorax and the abdomen. Okay? It's a dome-shaped musculo-tendinous sheath, separates thoracic and abdominal cavities. Thoracic surface as a superior surface, and it has a convexity, right and left side. The abdominal surface is concave and it has an inferior surface. So this is the basic thing, and it has got some openings in the middle, and it is a muscle which is taking origin in the periphery and getting inserted into the center. So it's the central tendinous portion to which the peripheral muscular portion are attached. That is the major thing. So periphery is a muscular part, central part is the tendinous part occupied by the central tendon. And the muscle fibers are directed upwards and inwards like a fan shape, which are all coming here. And relationships of the diaphragm, superiorly you have the pleura and pericardium. And inferiorly you have the peritoneum, liver, fundus of the stomach, spleen, kidneys, and suprarenal. All these structures which are there under the diaphragm. Now, the origin of the muscles of the diaphragm there are three origins. One, it has a sternal origin, it has a costal origin, and a lumbar part. So, the lumbar again is divided into medial lumbocostal and lateral lumbocostal. It is taking origin both from the vertebral bodies as well as from the costal margins. And that is again divided into a right crest and a left crest. And the sternal part takes origin from the xiphoid process, and the costal part takes origin from the lower 6 ribs, which interdigitate with the transverse abdominal muscle. And this is the lumbar part, which is the medial part, which you can see here. And this is the lateral lumbocostal, taking origin from the ribs as well as from the vertebra. And you have the right and left crest. And the insertion is into the central tendon. And it is a trilobar shape, attachment with 3 leaflets. And it has a middle leaflet which is triangular, apex towards the xiphoid process. Then there is a right and left leaflets. So all the 3 leaflets are attached to the central tendon, which is the tongue-shaped one. And 4 diagonal glands coming out from the central point of insertion to in front of the esophagus. Now, what structures pass through this diaphragm? Even though it is a partition between thorax and the abdomen, what are all the structures piercing or going through the diaphragm? Major structures. Can you name them?
Aorta, esophagus, and inferior vena cava, sir.
Inferior vena cava. At what level? What level of the vertebra?
8, 10, and 12, sir.
8, 10, and 12. Very good.
Yes.
So that's a lesser aperture which permits lesser and greater. These are all small structures which are going through. There is planking house, hemizygosine, and all those things. Sympathetic trunk and all those things which are there. But major structures are 3 structures: esophagus, aorta, and the IVC. So the mnemonic at 12. Sorry. So I8, 10 eggs at 12. I for inferior vena cava at T8 level. 10 eggs. Eggs is for esophagus, US spelling. And
Excuse me,
12
sir.
at
Screen
12 is
sharing
aorta.
stop, sir. Can you share your screen, sir? Your screen has stopped sharing.
Oh my God.
Yes,
Is
sir.
it okay
Visible,
now?
sir. Yes, sir. Visible.
Okay. So this is the 3 level. T8 for inferior vena cava, T10 for esophagus, and T12 for aorta. Okay. And aortic hiatus lies anterior to the body of T12. Why we have to know about this? When you want to do a celiac plexus block, you should know to what a level you have to be careful. So aorta is at the T12 level opening. So you can see these 3 pictures here, and aortic hiatus also allows passage for thoracic duct and azygos veins, and the smaller structures that are going through. And what is the blood supply to the diaphragm? Musculophrenic artery from branch of internal thoracic artery, superior phrenic artery branch of aorta, and lower 5 intercostal arteries and subcostal arteries, inferior phrenic artery. Nerve supply of the diaphragm, which is the major supply.
Phrenic nerve, sir.
Phrenic for mouth motor, okay, and also some sensory is there. So you always you have to divide the nerve supply into motor and sensory. Right and left phrenic nerves are the motor supply, and the venical trunk lies at the T8 level along with the inferior canal, where branches of right phrenic nerve are traversing. Sensory supply with the phrenic nerve innervates the parietal pleura and peritoneum, covering the central surface of the diaphragm, and the lower 6 intercostal nerves supply the periphery of the diaphragm. Okay, that is the sensory supply. Why? What type of sensory nerves innervate the diaphragm, and what is their importance? So we know that motor supply is important for contraction and relaxation, but why sensory nerves are also supplying a muscle? That is because both non-myelinated and myelinated phrenic sensory nerves are there, and they help to modulate the respiratory output during each breathing cycle. So this we will see the importance when you read about the control of respiration. And activation of the phrenic afferent increases significantly the diaphragm to continue work and develop its fatigue. Effective activation of phrenic nerve afferents is to modulate the sympathetic motor outflow also. And phrenic afferents also contribute to the symptom sensation and make one aware of the sensation of breathing. Normally, we are not aware of our respiration unless we go into some difficulty, which is called dyspnea. So the definition of dyspnea is being aware of one's own respiration. So that can happen during exercise or in some conditions where there is some obstruction to the airflow. That situation, it is the phrenic nerve somatosensory. These sensory nerves only tell you that you are breathing very hard with the difficulty. Okay? That is the reason for having a sensory supply also for the diaphragm. Now, actions of the diaphragm, it contracts and then relaxes, during which time the diameter of the thoracic cavity alters. So during inspiration, the diaphragm becomes smooth downwards, and there is an outward movement of the ribs to expand the volume of the thorax. And during expiration, it goes back to the dome shape, and also the ribs come back to that. So it is a recoil of the contracted parts. So it is a passive process. And the clinical implications are, if there are some gaps in the diaphragm, then you can have a herniation. Diaphragmatic hernia can happen. And if diaphragm is paralyzed because of injury to phrenic nerve, which we can cause iatrogenically when you give an interscalene block or during a stellate ganglion block, or if any injury causes a diaphragmatic paralysis, that may reduce the what position the diaphragm will assume if there is a phrenic nerve palsy. Will it become more flatter, or it will become more dome shaped, will become increased?
More dome shape, elevation of diaphragm.
It will get elevated. So it will reduce the thoracic volume. Okay, so that is a very important thing. So diaphragm is important for this. And applied anatomy of diaphragm is there's roles both besides respiration, it prevents herniation of abdominal organs. Penetrating or blunt trauma can injure the diaphragm, and muscle must be repaired as soon as possible to prevent any herniation. And hiccup during anesthesia usually happens because of the diaphragm recovers partly from the muscle relax at that time. And laparoscopic procedures, it can cause shoulder pain because of the irritation of the peritoneal side of the diaphragm. And there are two types of fibers in diaphragm. One is called the slow fiber, and another is called the fast fiber. And the causes of phrenic nerve palsy and its implications. It can occur during trauma or blocks like interscalene or stellate, and it can also cause elevation of the diaphragm and reduce the volume of the tract. So if you see the picture of before paralysis, you see the dome is here on this side. And after paralysis, you can see the dome is elevated very significantly to a very higher level. So the whole volume of the thorax has got almost 50% reduction has happened. So bilateral interscalene or deep cervical plexus block should not be given because of this reason, that it will cause bilateral phrenic nerve palsy, which will cause very severe breathing difficulty. And the unilateral phrenic nerve avulsion may be done for intractable hiccup. This is an older treatment, but nowadays not practiced. So patient who has an intractable hiccup for 3-4 days, in those days we used to give a phrenic nerve block specifically to avulse that particular, to block that activity. And sites of diaphragmatic hernia, which are happen in so many locations. And can you identify this picture? X-ray, what is shown here? This is the normal diaphragm. This is a clue.
Left phrenic nerve.
Left phrenic nerve palsy. See, the diaphragm is elevated here, and this is the right side phrenic nerve palsy. Okay, so this is left phrenic nerve palsy where diaphragm. So this sort of X-rays may be kept in the OSCE or in your practical exam. So you must be well versed that. Always make sure that the diaphragm is equal both sides. And unique features of the diaphragm, which are all the things. Just have to skip through that. It's a highly resistant muscle to neuromuscular blocking agent. So this is the last muscle to be paralyzed when you give a neuromuscular blocking agent, and the first muscle to recover. That is the important thing because of the high sustainable nature of the muscle. Now, after that completion of the 4 topics on anatomy, we will go to the physiology of control of respiration. How does spontaneous respiration occur? It is occurring because of the rhythmic discharge of motor neurons of respiratory centers. Nerve impulses from the brain are the responsible for this rhythmic discharge. So the rhythmic discharge, how it is regulated by changes in the arterial PaCO2, PCO2, hydrogen, which is called the chemical control of respiration. So we have 2 types of regulation. One is the chemical control, another is the neurogenic control. So there is a neuronal feedback loop. What is compensation? Feedback loops are controlled of control centers, sensors and effectors. Okay. So which part of the nervous system are responsible for neural control?
Pons medulla.
And only these two?
It's
Cerebral cortex also is very important. So cerebral cortex, medulla and pons comprise the neuronal control. What is the role of each one of these parts? The cerebral cortex is responsible for voluntary control. Whenever you want to hold the breath, we always do the breath holding test as a part of our pre-op assessment of the patient, isn't it? That time
Yes, sir.
only if the cerebral cortex is intact, you will be able to do that. So the cerebral cortex is responsible for voluntary control of breathing. Medulla and pons are responsible for automatic breathing. Okay, so that is the thing that you have to remember. And how these centers maintain respiration. The nerve impulses arising from respiratory neurons that regulate the activity of respiratory muscles, and they are supplied by the cervical thoracic spinal cord to innervate the respiratory muscles. And the rate and depth of breathing is controlled by input from these areas. So the physical changes in the lungs and then sensed by the mechanoreceptors which are there in the central and peripheral, and also there are central and peripheral chemoreceptors. These two receptors are only responsible for adjusting the pattern of breathing. So how is the control of respiration in the higher brain center, that is cerebral cortex, done? What is the central control of respiration?
cerebral.
CSF, you know, it is voluntary cerebral cortex responsible for voluntary control. The primary motor cortex responsible for initiating any voluntary muscle movement, including that responsible for respiration. So it is activated by signals that are sent to the spinal cord via corticospinal tracts. Subsequently, diaphragm and axillary muscles of respiration. So the cortex contains pathways that bypass the medullary neurons and go directly to these respiratory muscles. So why voluntary control of respiration is not possible indefinitely? When you ask the patient to hold the breath, after a few seconds or minutes, he will have to start his own respiration. Why? You cannot endlessly hold your breath, isn't it?
Yes, sir.
What is the
Due to
reason for that?
hypoxia or hypoxemia
Ah,
and hypercapnia, sir.
hypercapnia. So voluntary control of breath holding cannot occur indefinitely because chemical receptor stimulation by hypoxemia and hypercapnia override the voluntary control. Okay, that is the reason. Both hypoxemia and hypercapnia, they will stimulate the brain to induce respiration again because they cannot will override the voluntary control. What is breaking point? Breaking point is the time where you cannot hold your breath anymore. The point at which inhibition of breathing can no longer voluntarily occur is called the breaking point. That is the, so you ask the patient to hold the breath, after 30 seconds, he starts taking a breath, that is called the breaking point or the duration. That's the breath holding. Respiratory control, there are four main anatomical areas which are called the dorsal respiratory group and ventral respiratory group, which are situated in the medulla. And in the pons, you have two centers called the apneustic center and pneumotaxic center. They are collectively called the PRG. The role of medullary respiratory centers, these are one for inspiration and one is for expiration. That is the dorsal respiratory group is the control center for inspiration. So you remember ID, your email ID or whatever ID you want, inspiration dorsal, expiration ventral. So DRG is located next to the nucleus solitarius in the root of the cranial nerve 9. And the sensory afferents from peripheral chemoreceptors are via the glossopharyngeal nerve and vagus nerve. So motor output is sent to the diaphragm from the center via the phrenic nerve, and groups of neurons primarily controlling the timing of the primary cycle are DRG for acquired forced respiration and forced respiration, and the lower motor neurons innervating the external intercostal muscles and the diaphragm. These are the muscles which are supplied by that. And ventral group, the network of neurons extending from brainstem to the spinal cord and pons and medulla junction. The VRG, as I told earlier, is the center for expiratory muscle responsible for expiration. And the neurons innervate the lower motor neurons controlling the accessory respiratory muscles involved in active exhalation. Whenever you have to do a forced exhalation, you have to use the accessory muscles also, like in asthmatic patients with the breathing. So these neurons, they act at quiet respiration. They do, but expiration is a passive process, as I've been told regularly. And the arrangement between the neurons of DRG and BRG, they have reciprocal inhibition between the neurons involved in the inflation. So you have the rhythmic or cyclical alteration between inspiration and expiration because of the intercommunication between these two areas. And the role of spontaneous respiratory group, that is the apneustic and pneumotaxic centers, they have modification of rhythmic discharge from the medullary centers only, and they regulate the depth and rate. So these medullary centers are for changing from inspiration to expiration and expiration to inspiration. That rhythmic activity is from medullary centers, whereas the rate and depth of respiration is controlled by the pontine centers. And an increase in pneumotaxic output increases the rate of respiration, and decrease in the output decreases the increase in the depth of the respiration and causes a reduction. So the apneustic center responds to sensory input from the vagus nerve and regarding the amount of lung inflation and prevent over expansion of the lung. That is the main function of the apneustic center. And afferent input, which are all the increased cerebral arterial CO2 and how it causes the stimulation of the various centers. All of this you can read from the books. So change in the chemical composition will alter the rate of respiration. So always, you know, when you have a respiratory acidosis where CO2 is accumulating, it automatically triggers you to breathe at a faster rate, cause you hyperventilation to eliminate the carbon dioxide. So that is the mechanism of chemical control. And what are the types of respiratory chemoreceptors? So you have peripheral chemoreceptors and central chemoreceptors. Peripheral chemoreceptors, where are they situated and how do they function? They are also termed as arterial chemoreceptors because they are situated in the bifurcation of carotid artery and on the aortic arch. These are the locations we have. And the afferent impulses from the carotid body carried via glossopharyngeal nerve and ninth cranial nerve. And from the aortic bodies, they are carried by the vagus nerve. So the aortic and carotid bodies are the only chemoreceptors that respond to hypoxemia, whereas the central chemoreceptors will not respond to that. So they respond both to hypercapnia and hypoxemia. And the central chemoreceptors, they are situated in the medulla, very close to the ventral surface of the VRG. And they are stimulated by drop in cerebrospinal pH. That is hypercapnia, which will result in increased production of hydrogen ions, which will cause a decrease or acidosis in the brain. That will only stimulate the central receptor. Hypoxemia will not stimulate the central chemoreceptor. And what is the mechanism that all of you know? Hydrogen ion has to carbon dioxide always will combine with water to form carbonic acid. That is a routine thing. And non-chemical control of respiration is done by the mechanoreceptors and muscle spindles. They stimulate the respiratory center by the stretch receptors and muscle spindles. And these receptors are located in the bronchial smooth muscles also, which they put stimulated by overinflation. And neural impulse of these receptors travel to the apneustic center with the vagus nerve and result in reduction of deep breathing. And the pneumotaxic center, as I told you earlier, is for the alteration in the depth. So the reflex is also called the Herring-Brewer reflex, inflation reflex. And Herring-Brewer, it can have a inflation reflex as well as a exhalation or deflation reflex. And muscle spindles are also in charge of sending the afferent impulses to adjust the respiratory activity. So afferent pathway of proprioceptors located in the muscles, tendons and joints stimulate inspiratory neurons during exercise and stimulate the respiratory center to increase the respiratory rate and help clear the carbon dioxide and acid production during exercise. So this is the major importance of the muscle spindle stimulated activity during exercise and normal requirement of increase in the oxygen. And irritant receptors, these are located in the airway epithelium. So how they produce cough to clear your secretions is by the irritant receptors, and they are the ones which can also cause bronchoconstriction and stimulate ventilation as a protective mechanism against aspiration or inhalation of noxious stimuli. And chemicals such as histamine stimulate these receptors. The irritant receptors are stimulated by, that is why we give an antihistamine always when the patient has some irritable cough. We treat them with the antihistamine because of this particular reason. And there are other receptors called juxtacapillary receptors or J receptors, and they are non-myelinated C fibers which are in the alveolar walls and located close to the proximity of the pulmonary capillaries, just closer to the pulmonary capillaries, and they are activated by hyperinflation of the lung or during dyspnea, bradycardia and hypotension. And these intravenous or intracardiac administration of capsaicin leads to activation of J receptors and producing a reflex which is called the pulmonary chemoreflex. So the activation of this receptors is also called as pulmonary chemoreflex, which will result in rapid breathing, bradycardia and hypotension. So it is something similar to the Basal-Jarris reflex in the cardiac heart muscle which is happening. And occur in pathological states like pulmonary congestion and embolism, this juxtacapillary receptor reflex will come into play. And what are pain receptors and what is their role in respiration? Ventilation is stimulated by activation of pain receptors. So hyperventilation during acute pain has been proposed as a reflex to the respiratory component of fight or flight response, preparing the body for possible attack or injury. Now coming to the non-respiratory functions of the lung, they have their own defense against inspired particulate matter, filtration of blood by systemic circulation, handling of vasoactive substances in the blood, and release of substances used in the alveoli or circulation. So these are the four important non-respiratory functions. One is the defense mechanism. Second is the filtration of blood of the systemic circulation, handling of vasoactive substances, and also they act as the important reservoir in case of emergency for filling the left ventricle. So pulmonary defense mechanism by filtering the dust, pollen, fungal, etc. and humidification, heating of inspired air is also part of the non-respiratory function. Because respiratory function basically means exchange of gases, intake of oxygen and elimination of carbon dioxide. So these are all classified under non-respiratory function, even though it is part of the respiratory activity. And this nasal turbinates also have surface area about 160 square centimeters, and that is how they are able to heat the air that is inhaled. And the smell is another non-respiratory function which helps in avoiding the obnoxious or gases which can irritate our air passages. And filtration of inspired air occurs by all these mechanisms, including tonsils, adenoids have immunological defense function also. So that is why we normally say do not remove tonsils unless they are very badly infected and that is causing repeated fever and other problems. They are protective lymphoid tissues which should not be removed because they give a lot of immunological effect. And how these things are impacted and removed, we have to know how the filtered materials are removed. One is by the reflux in the airways, which will cause cough or sneezing, and that will cause or remove the forcefully all the secretions that are there. But the other important thing which we have to be aware of is the mucociliary escalator. How the secretions or foreign bodies that have managed to go down deeper the tracheobronchial tree, how they are removed is the important thing. And that is where the mucus secretion which is produced in the lining of the epithelium that is containing there, with the cilia, they come for help. So the mucus glands, the mucus are produced by the goblet cells and mucus secreting glands which are lining in the epithelium. And this mucus has two layers. One is the outer gel layer, which trap the inspired particles, and there is a sol or the liquid layer, which is below this gel layer, directly in contact with the ciliated epithelium. So this picture will help you to find out that this is the mucus, this is the outer gel layer. Because it is a thick viscous nature, it will trap all the dust particles. And this sol layer or the liquid layer, serous layer you can call it, which is in contact with the cilia. So this helps easy mobility of the cilia, and goblet cells and mucus glands produce these things. And this activity of the cilia will be always from the periphery towards the carina. So once the particles are trapped here, the ciliary activity constantly will push the mucus towards the carina, and once it comes to the carina, it irritates the carina and produces a cough reflex, and that is how you bring out the mucosal secretions with a trapped things inside the mucus. And the secretions not removed by patient suction or other remains in the airway obstruction will develop. So that is the reason why in post-op we must encourage the patients to clear the secretions on their own, or we must try to suck it out by a proper suctioning and aspiration. And there are some cells called dendritic cells or mononuclear phagocytic cells, and they inhibit the airways all the way, and that is they are spread all over the airways from the trachea to the terminal respiratory units. And when they are immature, they do phagocytosis of the bacteria or other antigens that are entering our respiratory tract. But after contact with the antigen, these cells they become mature and migrate to lymphoid tissue to promote tolerance to the antigen and prevent the immune response by releasing the anti-inflammatory cytokines. And if the antigen is recognized as a pathogen, it will activate the T lymphocytes, and the immune response will come into play to reduce the inflammation by stimulating the anti-inflammatory molecules. So these dendritic cells are very, very important as a part of the defense mechanism. And this is another picture to show the same thing. And one important function is as a reservoir of blood for left ventricle. The pulmonary, this is a structure, what we saw earlier is the function of the alveoli and other lung tissues, non-respiratory function. And there are some non-respiratory functions of the pulmonary circulation also. And one is the filtration of all the materials that are coming, preventing it going to the systemic circulation. And metabolism of vasoactive constituents, and as a reservoir for the left ventricle. So when the left ventricle output is to maintain few strokes by the blood that is stored in the pulmonary circulation only. When the patient goes into an acute hemorrhagic or bleeding cause, this blood in the, just like the liver can supply up to 1 liter of blood in emergency, the pulmonary vasculature containing the blood can also supply blood to the left ventricle in trauma cases. And the pulmonary circulation acts as a filter for the all the things that are passing through the pulmonary capillaries, and the particles that are filtered are small fibrin and blood clots, fat cells, bone marrow cells, detached cancer cells, gas bubbles, etc. And masses of platelets or lymphocytes are all removed so that they don't go and cause any thrombus formation in the systemic circulation. So if this function is not there, every one of us are likely to suffer from a stroke or a myocardial infarction. And there are lytic enzymes in the vascular endothelium, and by ingestion by macrophages and penetration of lymphatic system, all these substances which are filtered are all removed by this mechanism. And patients who undergo cardiopulmonary bypass do not have the benefit of this pulmonary capillary filtration, and blood administration to these patients must be filtered for them so that these small clots. That's why when you supplement blood when the patient is going on CPB, you have to have a proper filter of the blood that you are supplying. And fluid exchange and drug absorption, alloyed osmotic pressure in the plasma proteins is normally higher than the hydrostatic pressure, and when the lungs is rapidly, water is taken in the lungs, rapidly absorbed into the blood. This protects the gas exchange function of the lungs and opposes the transportation of fluid from the capillaries. And type 1 alveolar epithelium, pneumocytes, they pump sodium and water from the alveolar surface into the interstitium. And that is why we don't flood our lungs or alveoli with fluid all the time. And aerosol drugs injected to airways are only bronchodilators or isoproterenol, may rapidly pass into the systemic circulation and produce systemic effects also. That is why drugs which are administered through the respiratory tract, they are all of very, very small dosages. We say 50 micrograms, 100 micrograms, where oral or parenteral dosage will be in milligrams. We always give the drugs in microgram dosages. And they are also administered, they convert the vasoactive substances, storage and release of that, and they are also important for inactivation of some of the drugs. So prostaglandins are nearly completely removed. Up to 50% of endothelin 1 is also removed in a single pass through the lungs circulation. And 30% of norepinephrine produced in the body is also removed by the lung. And some substances, this removal activity is also called the xenobiotic effect. XENOBIOTIC, xenobiotic effect. And some substances released into the specific vascular beds are also passed through the lungs, and they are removed by that. So drugs which are administered via an arterial or venous catheter will have to pass through this. So if you want to prevent the removal by that, you have to go in for direct arterial infusion rather than venous method, which will have to pass through the pulmonary circulation. So that finishes the importance of control of respiration and thing. The next point is the bronchomotor tone. I think I will go through this faster and finish that because already we have gone into 2.5 hours. So what is bronchomotor tone? It is a state of contraction or relaxation of the smooth muscle of the bronchiole. And the factors which affect the bronchomotor tone, especially the depth of anesthesia, right? The plane of anesthesia can induce a increase in the bronchomotor tone and produce bronchospasm, or some drugs and vasoactive substances all can, inhalation agents all can increase the bronchomotor tone. So how is the smooth muscle contraction caused by the bronchial smooth muscles? As I told you when we saw about the bronchopulmonary segments, the bronchioles do not have a cartilage. They have smooth muscles and elastic fibers. So that is the location where the bronchial constriction can happen, and that is produced by the stimulation of the smooth muscle. And as all the muscles are being stimulated by the calcium, here also it is mainly by the calcium dependent influx. And How this mechanism, all of us know that L-type voltage gated calcium channels open and calcium will come into the cytoplasm, which will stimulate release of calcium by the sarcoplasmic reticulum. And this calmodulin will bind the calcium to prevent its excess activity. And once calcium is released into the cytoplasm, it will stimulate the myosin light chain kinase activation, which will cause phosphorylation of myosin light chain and increase myosin activity. So it will cause myosin actin myosin binding, cross bridging will happen. So this picture will tell you how the calcium enters, brain potential activating. So actin myosin complex has to be formed. That will cause a contraction, and once the contraction is over, the calcium will be removed and reinserted or sent back into the sarcoplasmic reticulum, and that will cause the separation of the myosin and actin complex, which will result in the relaxation. This all of us know. Nitric oxide also plays a role in that. Now, what is the nervous and paracrine control of airway smooth muscle contraction? The parasympathetic system is a major bronchoconstrictor, neural pathway, all of us know, and cholinergic nerve fibers are responsible for basal airway tone. So cholinergic fibers travel down the vagus nerve and into the parasympathetic ganglia within the airway wall, and parasympathetic ganglia density is maximal in proximal airways around the 5th to the 7th bronchial generations. And the short postsynaptic fibers reach the smooth muscles and glands. And acetylcholine is the main transmitter, neurotransmitter for parasympathetic, as always in other areas. And both ganglionic synapses and postganglionic junctions. Now, what causes bronchial relaxation? That is mainly by adrenergic stimulation. As you know that we give salbutamol or other adrenergic stimulants for relaxation of the smooth muscle. So beta 2 adrenoreceptors are largely present in the airways. And is there a non-adrenergic, non-cholinergic pathway also for bronchomotor tone? Yes, there is. And that is by these substances are transmitters for this NANC part of autonomic nervous system. So normally all of you know that autonomic nervous system is divided into sympathetic and parasympathetic. But there is a third component called non-adrenergic, non-cholinergic, where the transmitters are different, and they have the effect of both contracting and relaxing agonists such as neuropeptide Y, substance P, ATP, neurokinins, and VIP are the four transmitter substances which also can cause either contraction or relaxation. There is no clear-cut demarcation like parasympathetic and sympathetic. Okay, but this is not well developed in human airways, and that is the reason why they are not very much dealt with or given importance in our day-to-day usage. What other factors can influence bronchomotor tone? There, addition to autonomic nervous system, several cells located in the airway, like the epithelial cells, inflammatory cells, myocytes themselves, release a variety of mediators like histamine, endothelin, ATP, and the metabolic products of arachidonic acid, which modulate airway contraction via specific membrane receptors. That is why treating asthmatics involve not only giving beta 2 adrenergic, but also antihistaminic and other drugs, so that we have a release of the bronchoconstriction that is happening. Okay, so there is a lot more to go the physiology itself, like we have to see about the resistance, the compliance, elastance, and I think maybe all your brain should be exhausted with that. So I will have to definitely have another class to complete all that. So I can't rush through all those components of the physiology, because they are all practically very useful when you are going to operate or use a mechanical ventilator. Unless you know about your compliance and resistance and the mechanics of respiration. It's very difficult to understand. So I think I will stop here for the day. We'll have the balance for the next class. Okay.
Yes, sir.
Thank you, sir. Sir, we have asked two questions, sir. Students, have you got the answers? One is why 4% is used instead of 1 or 2% for topical methods? Lidocaine.
No, sir.
The number has dwindled. Many of them are shut off and gone. So,
The question is, what is the normal Wegel's angle of intratracheal tube?
so the answer for both, if you don't know, I will tell you. The reason why we use 4% is we use it as a topical application. And the areas where we use, as you know, the mucous membrane has got a lot of secretions. And this will dilute the drug. So if you use 2% or 1%, that will get diluted further, and the surface receptors have to be blocked for the effective analgesia or the anesthesia. That is the reason why we use 4%. Even if it gets diluted to 2%, it will still have some effect. Okay. Whereas if you take a drop and put it in a smaller area, you will definitely have the loss of sensation, even if it is 1% or 2%. But when you want to block a larger area, you have to definitely use a higher concentration because it is going to get diluted with the secretions of the mucus membrane. That is the answer for that. And the Megel's angle for the normal endotracheal tube is 140 degrees.
Yes.
It's an obtuse angle, it is 140 degrees. So to make it more acute, you bend it and insert that bevel into the adapter. That is the reason why you will do that bending and softening also.
Thank you very much, sir.
Thank you, sir.
Can we sign off today's meeting, sir?
Yeah, please. Thank you. Thank you very much.
Thank you, sir.
Thank
Good
you,
night,
sir.
sir.